very well. So we're really a family here, pediatric hematology oncology family, with one purpose besides socializing, which is to really take care of our children and to try to give them the best outcomes possible. With the resources that we have, sometimes a lot, sometimes a little bit less, but I think we all have the same goal. So along those lines, we have some excellent speakers in the morning in the first session. I'm going to ask Dr. Samuel from National Guard Hospital, Dr. Al-Madinah University, and from King Faisal to introduce our morning speakers and to kick off our session. Thank you very much, and hope for a good day today.
Thank you. I'm grateful today to be participating in this great conference. It's my pleasure to introduce the first speaker. He is very well known nationally and internationally. The first speaker is also Jeffrey Distinguished Chair of Pediatric and is Chief of Division of Pediatric Oncology and the Director of the Center of Childhood Cancer Research at Children's Hospital of Philadelphia. Steve is very known for his contribution to treatment and management of childhood leukemia. He chaired a lot of children's oncology clinical trials that led to improving the outcome of children. Without further ado, the podium is yours.
Thank you very much, Afshan and Sammy, for those kind introductions. Thank you very much. Today I'm going to talk about precision medicine strategies in ALL, and my disclosures are as listed here. Sorry, this doesn't appear to be advancing. Is there a controller, or am I supposed to be touching the screen? So when we think about how to target leukemias or any cancers, I think we first want to think about the multi-step pathogenesis of cancers. And it's very clear to need multiple mutations to develop a full malignant phenotype. In ALL, some of the earliest and perhaps initiating genomic abnormalities are chromosomal translocations. So as we think about how to target leukemias, I always think we want to think as close to the initiating factors as possible. Thank you. And chromosome translocations are an obvious target, or the proteins produced by chromosome translocations. Obviously, the most well-known of those abnormalities is the Philadelphia chromosome, or 922 translocation, which leads to BCR-ABL1 fusion. This occurs in about a quarter of adult ALLs and 3 to 4% of childhood ALLs, but that incidence increases with age. So if you look at older adolescents, older than any of you treat, you start to see that increase. When we look at the outcome of this entity before the development of tyrosine kinase inhibitors, it was quite poor. And this is a summary of 2 studies performed by the Al-Madinah International Group over time, and even in the latter one, patients enrolled in the late 1990s and early 2000s, we see that only a third of patients were alive in remission at 7 years, and less than half were alive at 7 years. And this is looking at patients treated without tyrosine kinase inhibitors. Obviously, tyrosine kinase inhibitors were developed to target BCR-ABL1, initially imatinib, later dasatinib, and then now quite a few different tyrosine kinase inhibitors, and many groups started to study the combination of chemotherapy plus the TKI. I should have said that before the development of TKIs, the standard of care for this disease was to try to get patients in remission and proceed to bone marrow transplant. And this is the first study from the Children's Oncology Group, now initially published 15 years ago, it compared historical control treated with a pre-tyrosine kinase inhibitor to a small cohort of patients treated with imatinib plus chemotherapy, and saw dramatic improvements in outcome, with event-free survival at 7 years increasing from 27 to 72%. As I like to say, you don't need a statistician to tell you those curves are different. Now, today, when we look, there have been 6 reasonably sized Philadelphia chromosome positive ALL pediatric trials published. All of them, from my perspective, have attained relatively similar outcomes. And here we see them in a table, and you can see event-free survival is largely in the range of high 50s to low 60%. Overall survival in the range of mid-70s to 80%. And certainly an overall survival in the range of 80% is dramatically improved from less than 50% in the pre-TKI era. And when you look over time, the most recent large international published trial was the combined COG-SFOL trial, AALL1122, and I think important aspects of that study, the results really were no different than others, but the number of patients who received cranial radiation drastically reduced over time. So in that study, it was only patients with CNS3 disease, and the percentage of patients who received transplant in first remission drastically reduced over time. In that study, only about 15% of patients. So the lessons that we've learned to date from Ph-positive ALL is that addition of the tyrosine kinase inhibitor to intensive chemotherapy improves outcomes substantially. Clearly, when you look and compare to the same chemotherapy without TKI, there is some added toxicity, largely infectious toxicity. Generally, this can be managed, but I think it's very important to be aware of, particularly during intensive phases of therapy. There is no obvious difference in outcome between imatinib and dasatinib. There's only one randomized trial in pediatrics that has been published, which was the Chinese trial that showed dramatically better outcomes with dasatinib. However, when you look at that trial, the outcomes obtained with imatinib were remarkably poor, and the dasatinib outcomes were similar to those seen in other North American and European studies. So I think we need further follow-up to fully understand if that is a real difference. Although I would say the field is now moving toward dasatinib, as we'll see in a minute. I think the other important thing is that cranial radiotherapy can be limited to those who who have central nervous system disease, CNS3, or perhaps can be eliminated for all patients, but doesn't need to be used routinely. And very importantly, pediatric patients who have a good MRD clearance can have good outcomes without consolidative transplant. And then the other thing that's important is before we had TKIs, one of the reasons we recommended transplant for every patient is if the patients relapse, you could not get them into a good remission and get them into transplant in second remission. Now we can get patients into a solid second remission with TKI, so I think it is safe to limit transplant in first remission to a targeted subset of patients. So this next couple slides summarizes the most recent COG-SFOL study, which has now been completed. Enrollment was completed in October of last year. We don't yet have any results from this study, but here this study used imatinib, and patients were randomized after induction to one of 2 chemotherapy backbones, the previous SFOL backbone, which is very intensive, and a still intensive but less so COG with ALL backbone. So I say we don't have results from the study yet, and we wait them enthusiastically. But I think one of the other important things is there were over 500 patients enrolled in this study. All Ph-positive trials in pediatrics I showed you before had between 50 and 150 patients. So this is a much larger trial. It will help us answer the question of the chemotherapy backbone, and also will allow us to have much better correlative studies given the larger patient numbers. Now, what lessons does this have for other ALL subsets? So from my perspective, It is an outcome for very high-risk ALL subsets can be improved significantly without transplant if there is a driver lesion which is fundamental to the leukemia. And this is the concept of oncogene addiction. Leukemia is addicted to the presence of this oncogene. If you can turn it off pharmacologically, the leukemia cells can die. And then obviously you have to have an effective targeted inhibitor, and you have to be able to use that, at least today, in combination regimens. So one of the key things to improve outcomes is to identify other genomic subsets that have targetable fusions, targetable genomic lesions. And within the COG group, we developed the so-called Target Initiative now over 15 years ago, and have published many papers with that. This was the most recent and definitive study of the genomic landscape of acute lymphoblastic leukemia. This was a collaboration between the COG and key investigators at St. Jude, with key efforts from initially Jim Downing and then Charles Mulligan and Jing Zong. And through those studies, we were able to perform detailed genomic sequencing, including whole genome, whole exome, and whole transcriptome sequencing in over 2,700 pediatric ALL cases. These were mostly B-lineage ALL cases. A subsequent paper has been published focused on T-lineage ALL very recently. And some of the take-home messages were that they were generally low mutation burden. 300 putative driver genes were identified, many of them previously unknown to be involved in ALL or involved in cancer. The spectrum of lesions varies with age, and some of those lesions have prognostic significance, and there are some lesions that add prognostic significance as secondary mutations. And one of the most important subtypes is the so-called Philadelphia chromosome-like, or BCR-ABL-like, B-lineage ALL. I'm going to refer to this as PH-like, but others refer to it as BCR-ABL-like. This was described independently by two groups, more or less simultaneously, now 15 years ago. The COG St. Jude Target Group, with a paper by Charles Mulligan in the New England Journal of Medicine, and then the Dutch Oncology Group led by Monique Denboer with a parallel paper in Lancet Oncology. And this subset is defined by a gene expression profile that is similar to that of Ph-positive ALL, but without the canonical BCR-ABL1 fusion. And it does show activated kinase signaling. There are commonly deletions or mutations in IKZF1, which encodes the transcription factor ICROS that is important for B-cell development. These are enriched in both Ph-positive and Ph-like ALL. And I think very importantly, this is a heterogeneous genomic subset, and probably, I feel, the important thing is the underlying driver genomic lesion is not the gene expression profile itself. So to understand the prognosis and theoretically to target these, you don't just want to know they have a pH-like phenotype, you want to know what are the driver genomic lesions. And the clinical features, the frequency increases with age from 10% in young patients with standard risk ALL to 13% in high risk ALL, 21% in adolescents, and almost 30% in young adults. Genetic subtypes vary by age and ethnicity. It's associated with high initial white blood cell count. Poor early response is measured either by increased risk of overt induction failure or high levels of minimal residual disease at end induction, and greatly increased risk of relapse and death. And this is a summary of several studies we published looking at the genomics and incidence in high-risk B-lineage ALL, so meaning patients over 10 or with a white count over 50,000. In this cohort, Ph-positive ALL is about 5% of patients. Ph-like ALL is about 22% of patients, so about 4 times as common as a general subtype as Ph-positive ALL. About half of these patients, at least in the U.S., have rearrangements of CRF2, and half of those patients have JAK fusion, JAK point mutations, usually JAK2, but occasionally JAK1. And in this group, IgH fusions are more common than T2RY8 fusions. About 20% of so-called ABL-class fusions, fusion genes involving ABL1, ABL2, the CSF1 receptor, and the PDGFR receptor beta. And so when you do the math, that is similar to the frequency of Ph-positive ALL at about 4%. About 5% have JAK2 fusions, and about 5% have truncating rearrangements of the erythropoietin receptor. And when you look at outcome, each of these genomically defined subsets has an inferior outcome. On the left-hand side, panel A, we look at ABL-class fusions. Panel B, the JAK2 fusions or the EPO receptor rearrangements. And panel C, the patients with JAK mutations. And we have targeted drugs available. So for the ABL-class fusions, I'm not going to go through the data today, but these can be targeted just as well as BCR-ABL can be targeted by similar tyrosine kinase inhibitors, imatinib or dasatinib. Cases with CRF2 JAK pathway lesions can be targeted by ruxolitinib. And so the next step was to start to test treating these with targeted inhibitors. And we've made progress in that area. So first, what was done, there were a number of retrospective and small studies, but the Ph-positive, the COG SFAL Ph-positive ALL trial I told you about was amended in 2001 to also include Ph-like patients with ABL-class fusions. And before that closed last fall, about 100 patients with ABL-class fusions were enrolled. So as those results come out, we will have more data on the outcome of ABL-class fusion patients treated prospectively. Now, currently the COG and SFAL have worked together to plan a new study. The study had to be redesigned last year when results of blinatumomab efficacy came out that I mentioned last night for those of you who were there. So the study has been completely redesigned, which delayed its opening, but the goal is to open this by July of this year. And so this will be a pilot study of chemotherapy plus blinatumomab in both Ph-positive ALL and Ph-like ALL with ABL-class fusions. And this is of that study, so for Ph-positive ALL and patients with fusions involving ABL1, ABL2, and CSF1, the CSF1 receptor, they will receive a lower intensity COG ALL treatment backbone with a single delayed intensification phase combined with dasatinib. So dasatinib will be started as soon as the fusions are identified. The patients will complete 4-drug induction therapy, and then consolidation therapy will be replaced with 2 cycles of blinatumomab. If the patients have not achieved a low MRD status at that point, they will then be off the study and considered as an event. And then for what we think will be the vast majority of patients who are MRD negative at that time point, MRD less than 0.1%, they will continue with chemotherapy. They will receive protocol M, so to speak, maintenance with high-dose methotrexate, a 3rd course of blinatumomab, then delayed intensification, 2nd interim maintenance, and maintenance therapy. And there are preclinical data that suggests that patients with PDGFR beta receptor fusions are more sensitive to imatinib than to dasatinib. One can debate those data, but at the end of the day, we decided because of these preclinical data, we would treat those patients with the same chemotherapy approach, but they would receive imatinib rather than dasatinib. So the goal of this study is really just to estimate the 3-year event-free survival of newly diagnosed patients with Ph-positive ALL. 100 patients will be accrued with Ph-positive ALL, and to estimate the survival of patients with Ph-like ALL and ABL-class fusions. So 100 patients of those will be described. And in parallel, we're designing a successor study to build on this. So I think this will be a very important study, introducing blinatumomab to this population, taking away some elements of chemotherapy. I'm going to go through all the data behind that, but this will be a step forward to less intensive therapy, building on the very important adult results that show we can treat Ph-positive ALL with blinatumomab, tyrosine kinase, and other very less aggressive chemotherapy. Now, switching gears briefly, I want to just mention the two other types of, one other type of genomic lesion I mentioned, and then come back to another one I have not yet mentioned. So I mentioned that ruxolitinib can be used to target patients with CRF2 JAK pathway lesions. And so the COG designed an AAL1521 trial, chaired by my colleague Sarah Tassian from CHOP. And this really was to understand and define the appropriate dose of ruxolitinib to use in conjunction with chemotherapy, and to assess at a pilot phase the outcome and look at different subsets. So the safety and efficacy of ruxolitinib with chemotherapy was identified with a recommended phase 2 dose of 50 milligrams per meter squared twice daily for 14 days of each cycle. This is a much higher dose than we used in other adult studies. We thought it was very important to define that dose, and we're very happy to see it was well tolerated. There are correlative studies that suggest that the JAK inhibitor sensitivity may differ between different genomic subsets. We will have to wait and see how that correlates with outcome. Enrollment was completed in 2022, so we're hoping to start to see some efficacy results in late 2025 or early 2026. And then I haven't mentioned it today, but another very important targeted subset of leukemia are those with MLL or KMT2A gene rearrangements. A lot has been understood about the biology of KMT2A lesions in recent years, and the menin, it turns out that a large complex containing the KMT2A fusion protein along with other proteins such as DOP1L has to bind to menin, and then that changes gene expression. And this binding pocket between menin and the KMT2A fusion can be blocked with a variety of drugs. The first one was developed by Syndex and is known as called revumenib, but there are at least 6 different compounds out there. I'm not saying revumenib is the best one. It was the first one developed, so it's the furthest along in therapy. So there have been important studies looking at the efficacy of revumenib in patients with KMT2A rearranged leukemias. And an important first study was just published this last month, actually, in Journal of Oncology by a large group that's listed here. And this showed that menin inhibition with revumenib, which they've got an easier name to say with that, but they didn't. So these were patients with refractory acute leukemia, and this is the Al-Madinah Al-Munawarah trial. 94 patients were treated, median age of 37 years with a range of 1 to 75 years. A variety of side effects were seen as expected. A unique thing you can see with this is differentiation syndrome, somewhat analogous to differentiation syndrome you might see in promyelocytic leukemia. And among the patients that efficacy could be evaluated, 57, the complete remission rate, complete remission or complete remission without hematologic recovery was 23%, which is actually pretty good in this population. And of the patients who had overall, 63% had a response. And among those who responded, 15 of 22, or 2/3, had no detectable minimal residuals. So I think this is clearly telling us that revumenib is active in this genomically defined subset of leukemia, and obviously the next steps are to test it in combination with chemotherapy. The COG started that several years ago. This is a trial that is chaired by Kelly Fall, which is AAL2121, which is a study of combining revumenib with 2 different chemotherapy backbones in infants with relapsed or refractory KMT2A rearranged ALL. So these are patients who were infants when they were diagnosed, so they were less than 1 year when they were diagnosed, but they don't have to be less than 1 year when they relapse. Because the patients relapse early, most are within the 1 to 3 year age range, a few older ones are seen. And the goals of this are to determine the recommended phase 2 dose of revumenib plus chemotherapy with 2 different chemotherapy regimens, an ALL regimen and an AML regimen, if you will, and also to better understand pharmacokinetics of this drug study, again, testing it with 2 different chemotherapy backbones, and this study was activated in November of 2023. The most recent update was that 6 patients had been enrolled without dose-limiting toxicities, 3-drug reinduction. An ALL type was enrolling at dose level 1, which was 130 milligrams per meter squared per dose every 12 hours. And then the AML subsets were enrolling at dose level 2, which is slightly higher. And I will stop with this, and I'd like to really acknowledge the people involved in all the studies I showed you today, particularly for the clinical trials. I'd like to acknowledge the study chairs of those clinical trials. Thank you very much for your time.
This great work to advance the management here. We can see the questions in the session. So we go to the next speaker.
Thank you. It's my great honor to introduce our next distinguished speaker, Dr. Faisal. He was renowned expert in pediatric leukemia. Dr. Faisal is a member of the Leukemia Lymphoma Division at St. Jude Clinical Research Children's Hospital, and serves as the director of the Pediatric Oncology Fellowship Program. He's well known nationally and internationally. He published more than 150 landmark papers in pediatric oncology. We are honored today that he will give us a couple of talks. The first one about advances in T-cell ALL, and then followed by target therapy and EMF. The floor is yours.
Thank you for the invitation. I'm going to talk about T-cell ALL first and followed by AML. Good. This is my disclosure. So as you know, T-cell coming from the bone marrow, hematopoietic stem cell, and then coming to thymus. And then thymus, they become EPP, early T-cell precursor, and then double negative, double positive, and then after that, single CD4, CD8. This is the T-cell development. And then during this development status, there's a mutation happening such as Notch1, TAR1, and early or later, and then stop differentiation, and additional mutation cause proliferation and become leukemia. T-cell leukemia is up to 15% of, around 50% of pediatric ALL cases, and higher in the AYA, 25 to 30%. And the male dominant female ratio is about 3 to 1, and high in African and low in Hispanic. It's Native Indian population is low. And the immunophenotypic cytoplasmic CD3 positive and TDP positive. This is basic, but the presentation when T-cell leukemia grow in the thymus, they present the various types. It causes a lot of problem for the early management, for the airway compression and vascular compression. Sometimes T-cell present with high white cell count and cause tumor-lysis syndrome and lymphostasis as well. And then they tend to go to CNS involvement. This is a CNS3 picture. And then early on, based on the development, we classify ETP, initially ETP, non-ETP, eventually near ETP was classified. ETP is a weak CD5 and CD1A and CD8 negative, and one of the myeloid population proton is positive. Near ETP is CD5 positive and similar to ETP, and non-ETP others. So percentage 16.7%, 71.8%. This is about this is COG data for the frequency. When ETP was presented about 15 years ago, Century noticed that ETP is associated worse event-free survival, the overall survival, especially high induction failure was very common in this ETP phenotype. And then recently, COG group showed that there is no significant difference in other group as well. between ETP, EATP, non-ETP, although still see some high induction failure in ETP, EATP group, but they can overcome. So now, this phenotype not explain the future prognosis. So this is a ALL prognosis factor, including B-cell leukemia. We know age is important, and the white cell count is important. Immunophenotype used to be B cells better. Of course, T cells still need intensified therapy. Now it's getting similar. And then extramedullary disease, CNS, and this is very important associated with outcome, and they usually upgraded to intensified therapy in POSS. And then MRD, measurable disease, residual disease, also associated with outcome. And also genetic classification is very important in both B and T. So these are associated with one outcome ALL. But looking at T cell ALL, most important factors, not everything in seen in the BLL. I think that extramedullary disease, CNS involvement is still associated with one's outcome. And also MRD remain to be very important. And recently, genetic analysis performed by next generation sequence tell us the future outcomes. So for us, CNS involvement, as I show here, there's a CNS3, 2, CNS3, 5 or more white cell counts in the CSF with plus, and CNS2 is less than 5 WBC is plus, and traumatic plus is RBC 10 or higher with a plus, and the CNS1 is no leukemia involvement. This COG data shows that in this study, CNS3 is associated with a worse EFS, OS, and then increased isolation cells. We recently studied imaging data, also matched with the CNS involvement associated with worse outcome. MRD is a very important factor. When microscope is not sensitive, MRD is very low level. We can go to such lower number, 0.0001%. Not very sensitive. This is a specific method because left leukemia diagnosis we can tell by microscope or leukemia. But sometimes if intensive chemotherapy is given and then bone marrow come back, we don't know if this is baby normal cells, normal progenitors, or leukemia cells. And in this case, actually, MRD performed, MRD was negative. So big cells are maybe normal cells, normal progenitors. So MRD method is sensitive and specific. We use several technologies by using flow cytometry, by using unusual aberrant immunophenotype seen in leukemia compared to normal counterpart. And also we identify a diagnosis, immunoglobulin T cell receptor sequence, and then we follow by TCR or now following NGS. These methods now very important to the future prognosis. NGS is not FDA approved for T cell leukemia, but many groups are using it. So this is one example. MRD is very important in the T cell leukemia, and also timing is also very important. Slightly complicated to explain, but this is a BFM, AIOP BFM study. I've left a slide show that there's a 1 day phase, end of 1 day, time point 1, day 33, time point 2. After 1 day phase, day 78. If both negative, standard is very good outcome. And then high risk, if day 78 positive at 10 to the minus 3 or higher, very bad outcome, EFS. In the middle, day 33 or 78, either positive, but 78 must be less than 0.10 to the minus 3. But anyway, it's MRD both negative is associated outcome, good outcome, and positive day 78 is associated very bad outcome. The important thing the left right is if day 78 time point 2 MRD negative, and then regardless of day 33 MRD negative or 10 to the minus 3 or higher, the bottom line does not show significant difference, p-value 0.66. So here, day 33 negative is very good, but if day 33 is not negative, if day 78 become negative, they have still, we expect still they have a good outcome. So I think there's a second chance for T-cell leukemia, I feel. One big phase is important to overcome the resistance for the one A phase. This is for similar result from COG. Endo-induction MRD capping 0.1% is associated with the worst outcome. And then endo-consolidation similarly, this is only limited to high risk, very high MRD endo-induction or induction failure patient only. Even such high risk patient of endo-induction, if endo-consolidation negative, defined by 0.01%, they have acceptable disease-free survival compared to remain positive after endo-consolidation, similar to Honeycomb 2. So now, in the genetic time, we have to understand next generation sequence. We are dividing ALL to multiple genotypes. And then recently published from the COG and Century collaboration, T-cell ALL is divided into 15 subtypes or more, actually, at least 15 subtypes here. And then they found that these LN2 gamma delta rate, and then I1, and the ATP like KMT12 is associated with a worse outcome. Also, ETP is a cross triangle near ETP, circle is non-ETP. These three groups scattered everywhere almost in the genomic subtype. So, these immunophenotype classification and this genetic classification does not match. Now, we are maybe these immunophenotypes, maybe classify immunophenotypes is still okay, but predict futures as shown in the COG study. Instead, genomics tell us we can classify very high risk, such as these three groups, or very low risk over there, and then combining with MRD, we can predict the 5-year event-free survival. It's now more complicated. We have to combine at least genomics and then MRD result to predict T-cell leukemia outcomes. So T-cell ALL outcomes really improving. And then initially we are thinking T-cell is worse than B-cell leukemia. This is the result from Japanese study. They showed a very good outcome, overall survival 91.3%. So very similar to B-cell leukemia. But important thing is always we see T-cell result is the difference between the overall survival and event-free survival is very minimal. This means that the rescue after relapse or something, after relapse or refractory disease, the chance of rescue is very difficult. So we have to treat in the first line, we have to make a big effort to treat and cure the T-cell leukemia in the front line. So many people study several randomized studies T-cell how to treat. And this is very about 40 years ago. This is a study done in animal comparing prednisone and dexamethasone. Dexamethasone in the time and the concentration of the CSF. Dexamethasone stay in the CSF longer than prednisone. This is one of the reasons dexamethasone has better CSF index. And then the reason is looks like protein binding. Plasma steroid binding. Dexamethasone, even low steroid concentration, protein bound is about 70%, regardless of the concentration. However, prednisone, if low steroid concentration, 100% binding to protein, means dexamethasone, there is a free dexamethasone that can easily penetrate the CSF. That is a possible reason that dexamethasone has a better CNS penetration and a better concentration over time. So several studies done comparing prednisone and dexamethasone. This is the example of the AIOP, PF comparing dex 10 mg per meter square versus prednisone 60 mg per meter square. The top one, 5-year cumulative incidence relapse is 10.8% versus 15.6%. This is significantly better in terms of the hazard is 0.7 in the death method. However, also notified was death in the before year and also death in the first year related to induction, because this randomization was only induction, was significantly worse in the death method, causing more deaths in the before CR or after CR. And the death method has been shown that like this, death relapse and better CNS control, and then no difference. However, many studies shows no difference in OS. And then, except this study showed prednisone good response. Initial 7 days, they respond prednisone. They have a better OS, but mostly no difference OS. Then 10 micrometers square per day is associated with the toxicity. So the people, many groups include COC, Century, and others, start using 60 micrometers per day, the dose we are commonly using now. And also, induction we use dexamethasone very often. Again, I mentioned that the 78 mRD is important because the dexamethasone is 3 level. So it is important this 1B phase. After the 1A phase, 1B phase is caused by cyclophosphamide, 6MP, and cytarabine should be given efficiently. Even 1A mRD is high, by giving these phase, some patients we can overcome and they will become negative after this phase. Then moving to later phase, and then it was when I saw this data, CAPIS-MTX and high-dose MTX and T-cell, CAPIS-MTX was significantly better disease-free survival, and as well as overall survival. And then this is possibly CAPIS has asparaginase plus MTX. Asparaginase is very effective for the T-cell leukemia. This is one of the reasons. And of course, some patients, mentioned that radiation timing, but I think this is very important that when high-dose MTX is not feasible, this alternative approach and is actually better in terms of T-cell leukemia. And then same study, almost report study, showed that Nenalo was associated better disease survival and also better CNS control. And then these agents can be combined in a T-cell leukemia. So in situ, to pharmacotyping, molecular subtyping, and then response evaluation. First, patient here will go through get the MRD, and then we do viral facts. And then also we do in the next generation sequencing, we classify by genetic subtypes. And then top, we start doing is using patient sample in vitro drug testing, and then check everybody's drug sensitivity. This can be used for the change in therapy any problem in the future. So while we are doing it, we noticed that T-cell leukemias, some of them are sensitive to dasatinib. And we know able transfusion, just Dr. Hanga mentioned that TKI dasatinib is sensitive to these cells. What we noticed was T-cell leukemia, some were sensitive, below the red line are sensitive. Pediatric 44% compared to adults 16.7% are sensitive. So about half are sensitive to dasatinib. So this was kind of unique, also surprised. And then we identified that these sample which is sensitive to dasatinib was slightly differentiated to double negative 3S3B, not the ETP. And then these ETP near ETP are more sensitive to BCL2 dependent, so sensitive venetoclax. Clearly, group are defined for those dasatinib sensitive ones, not venetoclax sensitive. For those venetoclax sensitive ones, not dasatinib sensitive. And then it is important that dasatinib is the blue one is a sensitive one, and then dasatinib sensitive one has a worse eventually survival compared to dasatinib resistant. Therefore, in this group, dasatinib is added, it may improve the outcome. So our substitute frontline trial now, we are using non-ETP. We use dasatinib plus 4 drug regimen. ETP, we use venetoclax plus 4 drug regimen. And then now a little bit couple of immunotherapy. daratumumab is multiple activity. One is daratumumab CD38 antibody, but it has complement-dependent cytotoxicity, or antibody-dependent cell-mediated cytotoxicity, or antibody-dependent cellular phagocytosis, or can kill the leukemia by cross-linking. So there's several mechanisms speculated. And then this is an international study showed that daratumumab in the relapse setting of T-cell lymphoblastic lymphoma. In the pediatric one, overall response of 83 is a great response. And then MRD negativity is 45%. And then 75% were able to go to transplant. As I mentioned, that relapsed T-cell disease is very difficult to salvage. But looking at the outcome data in the left line, child T-cell leukemia, about 30% alive with a median 8.9 months event-free survival. So there's one possible way to rescue the patient. And then I think COG is trying to use this agent in the front line next. Lastly, I want to mention about CAR T-cell and the T-cell. It's very complicated. This is more simpler picture because T-cell is attacking B-cell leukemia, CD19 tumor, targeting CD19. When you talk about T-cell or CAR T-cell, many people are interested in CD7 and CD5, which is commonly expressed in the leukemia cell, in T-cell leukemia cells. But we are trying to use similar approach in what we use in Kymriah or B-cell leukemia. So this is a problem because CAR T-cell can kill each other. CAR T-cell express CD7. If target CD7, not only leukemia kill each other or fratricide. And then also, we can live without this, it's not good, but we can eat the blood-brain and then the patient can survive. But it can kill normal T cells. And then can cause like a skip, like very severe compromise patient will be. And then sometimes, T cell lentivirus infect transfect CAR T product to the leukemia cells, and then they block the CAR T cell function or may proliferate. So these are a lot of concerns there. So many smart people are trying to avoid this issue when target CD7. One is gene editing, gene-based editing, CD7 knockout. And also intracellular retention of CD7 protein, prevent the expression of the CD7, and then natural selection, just make T cell, CAR T cell, and then only CD7 leftover cells they can use. And then otherwise CD7 negative cells selected in the beginning, and that one can be expanded. So people are doing several efforts to make a CD7 CAR T cells. And recently, a Singapore group published, again, CD7 or maybe CD3 zeta, but if CD7 is expressed in the CAR T, they kill. So they made an anti-CD7 protein expression blocker, and so this CD7 is retained inside the cell in the CAR T cells, and not CD7 is not expressed in the CAR T, so effectively can specifically can kill the T cell leukemia that express CD7. They have a very high MRD in bone marrow, peripheral blood before infusion, but mostly everybody become MRD negative. They show that excellent outcome, although preliminary small number, but mostly after transplant, they are alive and then showing some efficacy of this approach of the CAR T cells. So as a summary, T cell comprise about 15% of pediatric ALL. Risk factors are CNS involvement, MRD, and then genetic classification by next generation sequence are very important. And then T-cell outcome is very, very improved. And then dexamethasone during the induction, and very important to MRD positive disease by giving good BFM1 phase, PT, FTX, versus hydroxyl TX, and nelarabine, and the new therapeutic approach. Molecular target therapy starting venetoclax, immunotherapy, daratumumab, and CAR T cell. These are only examples, but they are emerging. Thank you very much. Go to the next one. Okay. Switching the gear, I talk about AML next. Then this is also challenging disease. We have to overcome. This is a disclosure. So I just want to talk these kind of issues. I want to, mention that AML is very heterogeneous in morphology and presentation, and then genetics, very heterogeneous. It's much more than AML. And then I want to introduce current approach of the pediatric AML, and also emerging target therapy. I think we need this. In the AML, we have a very good immunotherapy, target therapy, Dr. Hanga mentioned, but I think AML we need it. So, pediatric AML is very rare disease, like this here, up to 20 years old. And then 15 to 20% of pediatric leukemia are AML, otherwise mostly AML. And then only 5% of pediatric cancer. In the US, about 1,000 cases per year, and then incidence is 0.5 to 0.7 per million. Slightly high in infant, and then going up to teens, gradually increase, and really adult disease. So, but pediatric AML is very unique and different from adult AML. And genetic studies show that there's a significant difference pediatric AML and adult AML. When you look at microscope, when I studied medical field, I always look at a microscope. It's very heterogeneous. 1976, FAB classification was done, M0 to M7. One is possibly this M2, but here's an aware lot. And then M3, Pagod cells, a lot of aware lots. This is a unique M7 picture. CD41, 42, 61 positive. It's very morphology heterogeneous. And I don't show a picture here, the presentation can be heterogeneous. In this international massive gingival hypertrophy, leukemia cutis, or eye was protruding, intracranial mass, they can present in a very unusual way. So any leukemia, actually the AML is the same too. Leukemia happens from the stem cells. You have to differentiation, maturation of cell arrest, this happens first, such as driving mutation, ML1, CDP alpha, these ANX1 fusions, these cause maturation arrest. And additional mutation cause increased proliferation, and then accumulation of immature cannot make a final product, and then myeloid progenitors. And there's many pathways, including myeloid cell, monocyte cell, erythrocyte cell, platelet pathway. So again, genetic analysis is very critical to understand what is going on, this new heterogeneous morphology, heterogeneous presentation. So we do germline and also leukemia, whole genome, whole exome, RNA-seq, and then we classify based on these analysis. This is the RNA-seq data from the pediatric AML, about 1,000 cases. As you see the right side, there's many subtypes from the fusion or genomics DNA changes. So here, several groups, inversion 16, global factor MIG11, LAMS1 V1, 3S2 is very difficult disease to treat, APR, CDP alpha, and then several others are groups, KMT2A group, NAP98 group, and also MECOM group, or acute megakaryocytic and erythrocytic leukemia. We can group them, but still a lot of fast driver mutations, very heterogeneous. Next one makes me, I cannot see anymore. So left side is I see driving mutation, and then bottom is a secondary mutation. Tons of different mutations seen, very heterogeneous. And very common one is the RAS signaling, NRAS, KRAS, free IDD, TKD, WT1, KIT. So on top of these heterogeneous one, and these heterogeneous groups. This can explain how diverse, how different individual cases are in terms of genomics. However, these genomics again help, like we did for T cell. These genomics can be classified to the risk groups, lower risk, intermediate, high, and you can classify these futures, predict the overall survival. Not only that, by adding again MRD, like we did for T cell, these genomics plus MRD, such as low risk MRD negative is very good, but the low risk MRD positive decrease, such as combined with these genomics with MRD, we can classify the future of the other prognostic factors. Compared to AML, AML is behind in terms of survival. At best, 80% at this moment, and then average 75% overall survival, PFS about 60% range. We need more improvement. This is the data from the BFM. BFM is really gradually intensifying. The right side, you see anthracycline dosing. Now hitting more than 400 milligrams per meter square. They're using non-anthracycline toward the recent protocol. Also, cytarabine is hitting almost 50 grams per meter square total. Really pushing hard by giving chemotherapy. Looking at the change in the overall inventory survival and overall survival, actually, inventory survival is not much changing, not much significant change, except the first maybe 2 decades, two time point. But overall survival is improving. This means that we are able to rescue after the event by giving salvage therapy and then by giving transplant. But this is a lot of effort. Patients get first-line treatment, relapse, and transplant, a lot of toxicity and a lot of cumulative dose. So I think many groups are trying to use transplant, identify high-risk, I just mentioned genetic risk factors, MRD. We can identify high-risk group, and then we treat transplant with first CR. This is a trend from current management of AML. Highest patient going to transplant, and then BFM showed that first CR transplant improving outcomes to 78% in recent studies. This is busy because I have to show very heterogeneous genomics. So very busy. Essentially, this classification of areas like this, we identify everything, and then low risk transplant T1, and then CDF beta M1C11. These are 4 courses of chemotherapy, and others are 5 courses. But now even essentially, about 1/3 to 40% of patients get transplant after the 2 to 3 courses of chemotherapy. It's very heterogeneous, but these high risk are treated as transplant. More patients are treated in the first CR. Our survival really improving, but is it truly okay? Probably we have to think about this. When you think about chronic health conditions, gray is control, healthy population, and then blue is the patient who got chemotherapy, red is the patient who got transplant. A lot of toxicity is significantly higher toxicity seen after the AML therapy because therapy is intense already, and giving transplant makes more toxic. Mostly transplant patients are transplant related or some side effect. Hypertriglyceridemia, hypercholesterolemia, hypothyroidism, hypogonadism, chemotherapies, because anthracycline, cardiomyopathy, hypertension. We cannot ignore this. So again, we go back, we use a lot of transplant, but we have to think about how to smooth out, treat nicely or nicely. So when you think about these genomics groups, this yellow one can be targeted by many inhibitors. Dr. Hanger just mentioned many inhibitors can be used for these actually. FreeS2, folate receptor 1, and then FLT3 can be treated by FLT3 inhibitor. So next step, I'm going to move to target therapy for the AML. Hopefully, we can improve the frontline response and decrease the transplant, and then hopefully decrease the chemotherapy to improve the survival but also decrease the long-term outcome that I showed. So now molecular target therapy and immunotherapies are emerging. First, I want to talk about FLT3 inhibitors. We have been using more than 20 years, or maybe 15 years at least. FLT3 inhibitors, FLT3 TKD mutations are first ITP is seen 10 to 15% of pediatric AML and a high MRD after induction, and the associated worse outcome, especially ITP one-time ratio is high. And these can be treated by inhibitors, FLT3 inhibitors, sorafenib, ponatinib, quizartinib, and the type 1 inhibitor, prednisolone, ibrutinib. This one can block these ITD fusions, ITD mutations. However, there are additional mutations, TKD mutation, especially when happen with a ITD. They develop resistance to type 2 inhibitors, such as sorafenib. So, in this case, we have to use type 1 inhibitor which can block ITD and TKD. And ibrutinib is the most newer medication to treat this. This is an example we use sorafenib in the COC study, which shows when sorafenib exposed, DFS, disease survival, relapse risk is better than without when sorafenib is given. Next, inhibitors. It's many people are interested in these medications. Many interacts the KMT2 fusions and then increase the HOX-A, MICE1 activities and leukemia probe. Similarly, NP1 going to nucleus to cytoplasm. This cytoplasm NPM1 bind to many KMT2A complex and increase the activity as well. And NAP98 as well. NAP98 fusion associated with other molecules in KMT2A and leukemia become progressive. But as Dr. Haga mentioned, many inhibitors block the KMT2A many interaction, and then these MICE2, HOX9, PBX3 are downregulated for decrease the leukemia progression, but increase the CD11B and CD14 that cause leukemia defense apoptosis. Very attractive treatment. And then this was tested leukemia, relapsed refractory leukemia, AML and ALL, CR/CRh, 23% for those other response, median survival 6.4 months, and there are survivors, and then all patients still, several are long-term survivors. So this is a very attractive treatment. It is also important that pediatric, when you look at possibly effective subtypes, around 40% of pediatric AML can be treated by revumenib. So I think it's important to test this agent. And then at this moment, relapse refractory setting, in Central we have a protocol combining azacitidine, venetoclax, and revumenib, and we have been treating about 8 patients so far, and by using this phase 1 study, using revumenib combination. I think we need to move to combination studies. BCL2 inhibitor is very also, many people are interested. Venetoclax is a BCL2 specific inhibitor. So BCL2 keeps the pro-apoptotic protein by binding, but the venetoclax replaces this binding and release the pro-apoptotic protein and activate the back and then release the cytochrome C from the mitochondria. And this activates caspase and then cell going to die. This is a central study, phase 1 dose escalation study, and then 2 to 22 years old, and relapsed AML or expanded leukemia. At the dose level 360 milligram per meter square venetoclax, 1,000 milligram per meter square cytarabine, plus minus 12 milligram per meter square iodine. We see 14 out of 20 went to CR or CRH, and 2 out of 20 went to PR. Now we are testing this venetoclax central AML23 study. Venetoclax is conventional chemotherapy in a newly diagnosed AML. We have treated about 15 or 16 patients so far. Next, I'm going to talk about hypomethylating agent. It's HDAC inhibitors. This is another study showing that azacitidine plus venetoclax was significantly better than azacitidine plus placebo. This was shown in pediatric studies, and then 25 ml was treated, 12 are MRD negative. So promising efficacy. And then we use this, hypomethylating agent, ML16, azacitidine or decitabine with chemotherapy in newly diagnosed AML. I cannot show the result yet. This I think is very promising. And then next I move to immunotherapy for the AML, CD33 target. Myotag, temozolomab ozogamicin, CD33 antibody bind, and then cardiolysins is binding antibody. After binding to CD33, this antibody go inside the cells, and then after inside, release the cardiolysins for chemotherapy. And this is a COT study. Overall survival was not different, but event-free survival was significantly different. Better in the myotag go. So they analyze more. CD33 expressions is very important for the myotag efficacy. They divided 33 expression, first 25%, next 25%, next 25%, last 25% total. And then in this case, pre-KTD has more higher expression compared to what we have. Usually low risk leukemia. And then again, classified low risk, intermediate, high risk, low risk tend to express low CD33 expression, and others tend to express more. So when first order, there was no difference by adding myotag or without myotag. However, second, third, post order, event-free survival better when myotag was added. And the errors is significantly less. So CD33 expression probably matters. And then more analysis show that KMT2A, which can be associated with worse outcome, they specify CD33. And then essentially group collaboration with COG, CD33 can predict the CD33 expression, they can be associated with worse outcome. So we may be able to choose the patient who may be benefiting from the myotag. Next one is folate receptor 1. This is very bad, but mostly infant was when I see chemotherapy, I really feel tough because they don't respond very well. CBF and 2T3 really resist and mostly present active megacolic gastric but can present other morphology. But this is mostly infant, less than 3 years old, can be seen occasionally a higher age actually. And then looking at the overall survival significantly worse in these fusions. And then compared to other M7 megacolic gastric these fusions are pretty bad. Importantly, this fusion has a high expression of folate receptor 1. So there is a treatment of ovarian tumor, which is also high folate receptor, and then called lubentamab hazebibulin. So anyway, folate receptor antibody and binding chemotherapy or leukemia study. So similarly, antibody going into the internalized release chemotherapy. And then in this study, using this agent, the VS2 fusion AML, they see negative MRD in 41%, and then MRD positive 6%. This is a refractory disease, so I think this is very promising to use this agent in this group. So also, people are trying to use CAR T-cell by interior release target. There's still a lot of studies needed. So far, not strong promising data is available here. Some group use NK cells, activated NK cell or here mismatched NK cells, they show activities. And then we have used inhibitor nuclear export, cell export, that shows some patient other activities too. So summary, AML is very heterogeneous, morphologically and genetically. And then genetic classification and MRD are prognostic factors. Up to 70% of the AML can be cured with chemotherapy plus minus in the high-risk patients. Increased use of transplant is now we are seeing. And then, however, using transplant is not simple. It just increases toxicities, acute and late toxicities. And then there is an opportunity for the new therapeutic therapies, such as targeted therapy, immunotherapy, I just showed here. Thank you very much.
Thank you. It's the time for the questions, so please feel free to ask questions to the speaker. I think there is a circulating mics, so if you need the mic, please just raise your hand so we can grab the mic. So we start with the question regarding the use of the satellite in our please feel free to comment in the T-cell. So you mentioned the study now are using it as part of the study. What was that? Is that a randomized trial or it's being used for universal for the whole T-cell?
I think I have to mention that Central does not have a good number of patients. And then when we run this protocol, actually we invited Dr. Manga and others, big names, and then we want to make sure we are doing right. So Central now focusing pilot study. So we are trying to do new approach to inform bigger groups such as COG or European group to test in phase 3. So we are just doing historical comparison for MRD response actually. And comparing the COG has very rich data on the MRD response from the previous studies. So we are comparing MRD is one type point. Of course, survival is like historical. That's our approach now. It's not randomized, it's just one.
Well, I think what the St. Jude group is doing is very innovative. They look forward to seeing the results to try to, I think, we're laid it out very nicely. T-cell ALL, as we all know, once it relapse, you're in deep trouble. So we really need to get better therapies up front. This is a very rational testing. Set and one set to the next class, and the other set to very good to see the response rates. They see that it's a great set.
Can we have a mic to the middle?
Thank you so much for this talk. Just regarding the minimal residual disease, 33 versus 28. So you mean if it's 33 positive, so you will do the chemotherapy and then you repeat at least 28. If it's negative, that's going to be more important than 33 at the end of induction. Yeah, 47.
I think it's important, very important if the study is if negative, that's our optimal. Of course, if negative, usually they 78 negative. But still, I think our outcome is, if that is negative, is the best. But still, we can continue going chemotherapy if day 78 is negative. If that time
Thank you so much, Dr. Nago, for such a rich presentation. My question regarding PDL and MRD, comparing MRD by flow cytometry and PCR, where we actually sequence the IGH, the difference is 0.01 between the two. But how do you see that difference clinically? Is that actually worth trying to do PCR by MRD or flow cytometry might be very similar? I saw one graph that shows very close lines between the flow cytometry and PCR.
We have only evidence at this moment for that measure. And then we are still using the current decision making is based on that measure. We are still parallelly doing it. And I don't know if you're getting next protocol the NGS to the time decision making. We are not there yet. Of course, if NGS positive available induction, low negative, we probably keep following. And then if persistent is positive, we need to make action. But basically, we are protocol-wise, we still decide to go that way. But I want to hear from you.
We also, for T lineage AML, which I believe was what your question was, we also are relying on flow cytometry for decision making. I think I agree with everything Roberto said. I think one of the disappointing, if you will, things is that the NGS sequencing, if you do NGS sequencing, which we're very interested in lineage AML, because the overwhelming majority of patients have a marker that you can follow by NGS sequencing down to 1 in a million cells, but in T-lineage ALL, there's actually a reasonable subset of patients that don't have a marker by NGS sequencing. So I think that that's going to limit its long-term applicability, or at least you're always going to be flow cytometry. I shouldn't say always. For the foreseeable, immediate future, you're going to need flow cytometry to complement any NGS-based sequencing in T-lineage ALL, just because of the reasonable percentage of patients who don't have a marker.
Thanks for the talks. I have two questions, one for Dr. Hunter and the other for Dr. Yang. So the first one for Dr. Hunter is about the Lina and the pH positive patients. So I saw the newer study that is going to launch, and I noticed that the Lina is back-to-back consecutive in the schema. Probably, similar to the high risk or the relapse cases more than the current upfront therapy established recently for the AL. Is there a reason? Is it because to get for a deeper remission or the MRD assessment? It's just
I think, first of all, thank you for that question. It's an important issue. I think when you're talking about blinatumomab and pH positive ALL, you have a wealth of data from the adult trials. The patient numbers are relatively small in the combinations of blinatumomab plus TKI, perhaps the most exciting being ponatinib. But really remarkable response rates. So when you think of using blina and pH positive ALL, you actually are, with the TKI, you're kind of going at the cells by two different directions. So I think the group designing this study felt more confident using blinatumomab to replace elements of chemotherapy because you're doing a second parallel targeted approach with the TKI. So we're very excited by that study because it would eliminate the 1B consolidation phase. Hopefully it will be successful, but that's the rationale behind using 2 consecutive cycles is to try to completely eliminate the 1B consolidation phase and because you're coming out from 2 directions with both blinatumomab and the TKI. And that's also the reason for having reduction failure. Patients don't respond, and they would be off study, but presumably you would then aren't enough to tell you how to treat them, but presumably they'll go back to chemotherapy if they're not responding to the 2 times.
questions again, but regionals COG are looking into a newer product, I believe also Sanju. But what is your current standing? I mean, we're more used to sorafenib, but ibrutinib and others are being studies, but there's always some concerns, for the newer products in pediatrics. So what is your usual take, like FLT3 inhibitor as an upfront therapy?
Sorry, what?
For FLT3 AML, your TKI, like your FLT3 inhibitor choice as upfront currently, the newer ones or sorafenib?
Yeah, I think I see that I have a time I've been treating, before FLT3 was used and after FLT3 I did inhibitor used. We see better MRD response in the frontline setting. We cannot use induction one because we don't have a result right there. So induction one very high MRD similarly, but induction two, when we didn't have a TKI, higher MRD in induction two, which is now, we have only historical comparison, but better MRD response after using FLT3. However, I see prolonged, if you use prolonged FLT3 TKI in this setting, there is a risk that patient develop additional mutations like a TKD and then develop resistance. So our strategy is if donor is available, I think we should quickly do transplant. And then this has been having low MRD at that time, which we are successful to bring to transplant. That's our strategy. We see better MRD response, and also COG studies show that in the response to the front.
Thank you, Dr. Rick and Dr. Nava, for the great talks. I think just an open question for both of you. Your take on transplant game patient with positive MRD?
So we have shown that, I think, 2012, we intensively reviewed what's the MRD positivity in the before transplant, out different area, we need MRD negativity. Somehow we see up to 5%, it's reasonable, still not 100%, reasonable transplant accuracy. So we allow, in some time, with the IDP, it's very difficult MRD, for some patients cannot become MRD negative. No choice, because chemotherapy toxicity is not named after 3 courses. Still MRD weekly posting, we tend to go to transplant by using any modifier. Central government is half of sibling week before, around 5%. So hopefully, we don't know what. Of course, negative.
Yeah, I would agree with Roberto. Negative is better. Clearly, prefer negative MRD, but I think at least our transplant program is willing to transplant AML patients with positive MRD if it is stable, not increasing. They prefer negative, but I think what they don't want to see is increasing. And I agree with Roberto that you can transplant AML patients. You can, some of you, if you look at some of the older adult studies of AML, they were transplanting patients, with M2 marrows and getting fairly reasonable outcomes. So for AML, you don't seem to have this negative control. You want it, don't get me wrong, you want it, but it doesn't seem to be a requirement. And there's always the trade-off between, how much therapy do you give to try to convert a patient to MRD negative and risk infection or toxicity that will, preclude transplants. I think these are always very hard choices because giving them more therapy if you give them MRD negative may also cause toxicity that makes transplant impossible or more problematic.
Maybe one more last question.
always wonder if MRD differences in two relatively close time points are related to cellularity, more robust recovery. But what we don't want to see is, 5 to 10-fold change, 0.1 and then 1. That would clearly be increasing. If you're 0.04 and then you're 0.07, who knows what the difference, if that's real. So, we look at half log to a log difference is increasing functionally, but we do debate and sometimes argue.
One last question, if you allow me. Since you're product technology studying pH positive BAL, do you routinely test for TKI resistance in those patients?
We do not test routinely at initial diagnosis. It's extremely rare in pediatrics to have de novo resistance. We always test at relapse for resistance mutations. The incidence is a lot lower than reported in adult studies, probably because our treatments are more intensive and coming after the lower levels. So in the COG-PH positive ALL studies, again, not huge numbers, but probably in the 10 to 15% range with the resistance mutation at first relapse. Certainly second or third relapse higher, but we would always test at the time of relapse and not routinely at diagnosis. And usually we'll switch, if we can, we try to switch TKI information because the testing takes a while to come back. So if a patient is treated with imatinib and then relapse, we will treat them with the satinib until we know the results of TKI testing. TKI mutation.
With that, I'd like to conclude this excellent session. Thanks to Steve and Ian for all these excellent talks and discussion. I think there is ongoing discussion for the day. Thank you again, and we are happy to move forward to the next session. Thank you very much.
Just open it.
The next sessions, I think we will move to cellular therapy and bone marrow transplant talks. I would like to invite Dr. Ahmed Srehi and Dr. Hassan Ablusi to introduce our next speakers.
Good morning, everyone. Assalamu alaikum. It's my pleasure to introduce the first speaker of this session, Dr. Ali-Ahmari. Dr. Ali-Ahmari is Director of Pediatrics in St. Sudan and CAR King Faisal Hospital, and also he's the Director of SLH program, is a Professor of Medical College, King Faisal Hospital, and as one of the top leaders in the developing CAR T-cell program. He is going to talk about the King Faisal experience.
Assalamu alaikum wa rahmatullahi wa barakatuh. How can I show the slide? Yeah. Yes. Can you put the slide? Assalamu alaikum. Good morning, everybody. Thank you for this kind of introduction. Happy to be in Medina with colleagues and friends. I would like to thank the organizer for this kind of invitation. I have been asked to give you just a brief update about CAR T-cell activity at King Faisal Specialist Hospital in Montreal. Is this the one? I have nothing to disclose. These are the outlines of my presentation. You know why it's going backward? Can I have somebody from IT, please? Is this the one? So, you can see in this slide, this is the milestones of development of CAR T-cell therapy. So the idea actually was very old, as you can see here, very early, but actually the idea to be tested in labs and to be tested in humans is still recently. So as you can see here, introduction of 4-1BB molecule 2024, followed by first trials of CAR T-cell therapy in patients. First generation CAR T-cell construct was 2006, followed by the second generation of CAR T constructs in 2011, and then the breakthrough using this type of therapy in first pediatric patient worldwide. MUIT was 2012. And then the first approval of gene therapy in man actually worldwide was 2017, which is Kymriah, which was approved for use for refractory BCL and also BCL4 in adult. And since then, there are many CARs really in the market now approved by American FDA and other regulatory agencies, many of them also in China. So it's still, this is the future for CAR T in the coming probably few years, and there are thousands of clinical trials going really for leukemias, tumors, as you heard from the lecture yesterday. So why there is unmet need for CAR T-cell therapy? At the pediatric hematology oncology community, we are proud really with this achievement. As you can see here, we achieved very good really, number of patients cured with B-cell leukemia. However, still we have 15 to 20% of those patients eventually relapse, and some of them very difficult. We have challenges really to cure them. So after this study, Eliana study, which really was breakthrough to achieve 80%, more than 80% response rate in very refractory patients that failed any lines of chemotherapy, and most of those responder, or 95% of those responder was MRD negative at day 28. So it's a durable remission. So that was really good step really in the management of those refractory leukemias. So after that approval, actually we started at King Faisal Specialist Hospital to try to build a program for CAR T-cell therapy. So we started negotiation with the manufacturing company in 2019. It took some while because 2020 is the corona years. In spite of that, we managed really to get it approved in October 2020 by Saudi FDA, and then followed by our center to be certified as CAR T-cell therapy site in November 2020, and successfully we have treated the first patient in MENA region in December 2020. So these are indications that was approved by Saudi FDA. It's very much the same indications in the registration trials: refractory to first line, refractory to first relapse, second or greater relapse. Those are not eligible for stem cell transplantation or who relapse after stem cell transplantation. So our journey actually, because at that time there is know-how, it was zero at that time. So we have to meet everybody because as you know that a lot of logistics and coordination behind this, because it's autologous kind of therapy. You have to collect T cells from the patient, cryopreserve it, send it abroad to the manufacturing through actually after approval by FDA, custom release and approval, then getting back those products again with the same steps and infusion. So we need a lot of logistics behind this. Some regulations have to be started from scratch, so it took some time. So these coordinations really went smoothly, however it was a bit slow to coordinate between all those FDA and customs really approval, also shipping the product, getting the car again, and cryopreserved it and infused. And I think the most difficult part of this journey actually how to be ready for CAR T-cell therapy. So we started in-house training for all teams, pediatric and adult, including very much every service in the hospital, from different medical teams, ICUs, emergency rooms, and also to prepare for financial support. And that really it was difficult to have the approval especially for the cost for that. But it was really it was successful, and because the logistics and the steps really was many steps. So we created a flow chart to make it easy for our coordinator to go from receiving the patient, from referral till actually apheresis, cryopreservation, and then shipment, and keeping the patient, the disease of the patient under control till we receive the products back and CAR T-cell infusion. So also part of that actually we took time really to train every single medical team, nursing, physicians, to monitor and able to treat the most common toxicity, cytokines related syndrome and neurotoxicity. And we developed a system for that and then integrated to our IT software in the hospital, so it will be easy for everybody. So CAR T-cell therapy is a potential long-term remission. In the left side of the slide, this is really right. The first girl was treated with this in 2001. She is now maybe more than 13 years and she is disease-free. So it's our really inspiring, successful story worldwide. And we have our local experience here in the left side. It's Ahmed, the first one treated, and he's almost 4 years now. He is still alive. However, he is salvaged also by post-CAR T-cell with stem cell transplantation. So, having said that, everybody is really happy about CAR T-cell therapy, and in the beginning, many people believe that scans alone therapy, but people realize that there are some recurrences post-CAR T-cell therapy, and people start really to think how to save those patients by doing consolidated stem cell transplantation. I elected today really to give you the other phase of CAR T-cell therapy and the challenge part of that. So I selected one of our cases. This is a 7-year-old boy referred to us from National Guard Hospital in Jeddah, who was diagnosed as B-cell ALL since 1 in April 2019. He developed, unfortunately, early isolated bone relapse. As you can see here in the right side, this is what shown by Dr. Stephen Hanger yesterday. So this is B-cell who relapsed early, so you can the inferior outcome in the red curve. So to save those patients, the only option is to make them in remission and then taking them to stem cell transplantation. So this patient actually was reused with ALL unfortunately, he continued to have persistent MRD at end of induction. He failed really 2 cycles of Plina followed by flag and only responded to 1 cycle of inotuzumab and became MRD negative. He was transplanted using hematopoietic stem cell transplantation in December 2020, but unfortunately, 6 months after transplantation, he developed second relapse. So the option actually is even worse now. As you can see in the right side, the outcome of those patients who relapse after stem cell transplantation is really difficult. So if you can see the bottom curves here, the options really are the event-free survival is very low, and especially those who relapsed early, 6 months post-transplantation is almost 3% the event-free survival. So what happened to this patient? He received actually again in the upfront he failed Plina, so and responded to Eno, so he was treated with 2 cycles of or 1 cycle of inotuzumab and another cycle, and he became MRD negative. So as you can see here, we have chemotherapy is actually can induce remission, but will be very short remission. Plina is the same thing, can induce remission. However, this patient failed upfront Plina and is also temporary remission. The only option really is CAR T-cell therapy that led to be durable remission. So this patient was referred to us, T-cell collection, followed by CAR T-cell infusion in March 2020. He became MRD negative at day 28, which is really everybody happy at that time. But 4 months post CAR T-cell, he lost his B-cell aplasia. And this is really a red flag really for relapse. As you can see here, the famous study by Silver and Italian, when they really correlate the B-cell aplasia or loss of B-cell aplasia with relapse. As you can see here, if you lost your B-cell aplasia at month 3, then the risk, the survival is very low. And also at month 6. So the survival improved after month of 12. So the longer the B-cell aplasia, the better the survival. If you lose the B-cell area, then think about relapse. And this is what happened with this patient. So 4 months loss of B-cell aplasia. So 8 months exactly, he started to have fever, thrombocytopenia, bone showed more than 70% of blast, and still CD19 and CD22 positive. This is the area, to just remind you, Diana is the event-free survival 2 months, 50%. And later on, as we can see, this event-free survival continued to drop. So we did not reach plateau. So we did not really consolidate because at the time everybody believed that CAR-T can be standard therapy. But actually this good meta-analysis showing consolidating CAR-T cell post CAR-T is really better survival. So you can see here on the top, those patients in NCR or MRD after CAR-T cell therapy, the hazard ratio here favor consolidated stem cell transplantation. And also the relapse rate is less. So this patient actually after the relapse, after CAR-T cell therapy, was subject with chemotherapy, high-dose methotrexate, and he became MRD negative. So we did not think about CAR-T cell for the second time, although he continued to be CD19 positive, because many things, logistics, as well as also there are no encouraging reports actually to go for that route. So we decided to give the second stem cell transplantation, taking into consideration the high toxicity and the relapse rate at this time. So So you can see in the right side, this is from EMT showing almost 50% of those patients will eventually relapse. Not only that, and the non-relapse mortality is very high in the right side. 5 years is more than 22% of them. So that's what happened. Actually, those patients, this patient relapsed after the second stem cell transplantation, almost 6 months. So again, this, the only option for him is second CAR T cell therapy. So we received 2 transplants, 1 CAR T, and since he relapsed and still CD19, so we collected T cells, manufactured and infused for the second time. And he's almost now 9 months post second CAR T, and he is disease free. Hopefully, he will continue to be free of disease for the rest of his life. But this patient received 2 CARs, 2 stem cell transplantation. In the right side, you can see here, those subgroup of patients showed promising results, especially those who were transplanted as consolidated stem cell transplantation. So after second CAR, they are having better survival compared with that. So moving to our experience at King Faisal Specialist Hospital, just to give you just idea about the central data unit or the clinical trial units. There are 38 clinical trials, most of them on hematology oncology, and most of them sponsor clinical trials. And this is actually now they are really recommended or actually mainly strategy to improve investigator-initiated clinical trials in the coming few years. Most of these studies phase 3, so also there are strategies implemented to increase phase 1 and phase 2 clinical trials. Back to CAR T cell therapy, we have completed 2 clinical trials at King Faisal Specialist Hospital. All of them multiple myeloma, using 2 different products by 2 different companies already completed. And actually, there are a lot of ongoing strategies going at laboratory level. And they came up with the research team with a platform, they call it SWIFT CAR T platform. It's basically similar to what's in the market, using 4-1BB and different targets. They are planning to T cell and NK cells. The good thing that they claim that the short manufacturing time for this platform, only 3 days of manufacturing, which is really it's a good thing really to have. Still in the early infancy, they are going to use it for different antigens, leukemias, B cell, T cell, AML, also multiple myelomas, solid tumors, and not only that, also for autoimmune and genetic disease. But it's still very early in the designing phase and early development. In-house production, we have 1 ongoing clinical trial, almost really ready to recruit patients, already validated, approved by Saudi FDA. In the coming few months to recruit patients. This is CD19 in adult B-cell leukemia, and probably there are the pipelines for lymphoma and pediatric ALL. About the commercial cards that we have currently is Kymriah, of course, Axicel for adult lymphoma, and recently T-Cartus. We have treated a couple of patients for adult B-cell ALL, and in the coming few months, Cilta-Cel for multiple myelomas. How many patients we have treated so far? As you can see here, 127 for as of December 2024, 127 patients in the adult program, 32 in the pediatric program, and 4 clinical trial. So the total 163. Back to our experience at the pediatric side, we have treated 32 patients. As you can see here, the toxicity comparing our result with Eliana as well as real world data. We are somewhere in the middle. However, we are still have a higher rate of CRS, any grades, and also ICANS. Probably we did initially several cases with high disease burden, but now we try really to make all effort to decrease disease burden before infusion. ICANS, as you can see here, 12%, but all our cases grade 3 and 4. The outcome, comparing the outcome with Eliana trial, this is the last update of Eliana trial, 3-year event-free survival on the right side and our result in the left side. So we have here at 6 months, 12 months, 2 years event-free survival, very much similar to Eliana's trial. We have a little bit really lower event-free survival compared with Eliana at 3 years event-free survival. So now the challenge really in CAR T-cell therapy is the events that occur after CAR T-cell, but still we have excellent survival for those patients. So in order really to prevent these events, the only options for us here and in the kingdom is stem cell transplantation. Actually, we don't have access to CD22 clinical trials. So the only thing is consolidated stem cell transplantation. Recently, we applied this strategy. We have done 9 patients post-CAR T-cell therapy at day plus 60 to transplanted immediately, especially the transplant-naive patients. And you can see here, still really, although the p-value is not significant, but probably with more patients will have significance. So it's really promising for those patients. The survival and event-free survival is high for those subgroup patients. So, in conclusion, CAR T-cell therapy is an effective treatment option for patients with refractory relapsed B-cell ALL. CAR T-cell therapy must be delivered only in certified centers. Post-CAR T-cell relapse remains the major cause of treatment failure and can be predicted. B-cell recovery within the first 6 to 12 months after infusion predicts the risk of relapse, as we have shown, and larger real-world studies are needed to assess the effect of using allogeneic stem cell transplantation following CAR T-cell therapy. Our global experience demonstrates comparable efficacy and safety to those seen in the registration trial as well as real-world data studies. The right side, you can see here the Minister of Industry is really launching the Saudi-made logo in first electric car in Saudi Arabia. And you can notice here the number of plates is 2030, which going with the vision of Saudi vision. This goal achieved before 2030. So hopefully the other goal, which is Swift car platform, will be achieved by the end of this before 2030. Thank you so much.
Thank you. I will get back to you.
Thank you, Dr. for this. It's a pleasure to introduce our next speaker, Dr. Al-Madinah, who is an associate professor at the University of Science in Riyadh. He's a consultant, deputy chairman of the Department of Pediatrics, head section of HSCT and senior therapy at King Abdullah Specialist Hospital, which belongs to National Guard, the Ministry of National Guard. It's a pleasure
a bit different topic to talk about target therapy post-transplant because this area is very debatable and the data there is not as strong as the pre-transplant part. There's nothing to disclose in relation to this talk today from my side. I will go through some introduction and then we'll tackle certain diseases, particularly AML, and then just a few slides about autologous transplant. I will also pass through a lot of talks since Dr. Hunter and Dr. Inaba have already made my life easy in the previous talk about target therapy. So we'll just have some few points here. We'll start with ALL, and also this has been already discussed earlier from all the work has been done by St. Jude and the COG for this paper, and how, for example, targetable therapy and pH positive and pH like ALL are increasing particularly with a older age. Also, just to put points, the effect of genetic print and the MRD is always something to keep in mind. The pre-transplant MRD already has been elaborated in the previous session that in ALL we really need negative MRD prior to transplant for a better outcome, and this has been illustrated very clearly in many studies, and this is just one example of them looking at outcome. Also, I must mention that in the forum study for ALL, the standard care of conditioning, and it has been for a long time, even prior to this randomized study, that TBI-based regimen is the standard of care for all patients with ALL for more than the age of non-infected, more than 3 or 4 years. TBI is a cornerstone, and this is really the published outcome in that famous GCL study. And you see the red line is the TBI-based versus the chemo-based, which is TBF or traceolfan-based. I must also mention that in ALL target therapy, it has been discussed that TKI, so imatinib is statin in the 2000s, and then looking at target, or like it's immunotherapy rather than target, looking at brenetafusp and CAR-T in the consecutive years, and in the last 2024, revumenib, the menin inhibitor, has been approved. So going back to the forum study in the last, in ASH 2023, there was a sub-analysis of post-BAT looking at, I will focus here on BCR-ABL because also they mentioned the hypodychloride, but that's the outcome for a low number of patients. But you look, it's a bit lower, of course, than the other indications, but it's still fairly very good post-BAT in 50 patients who were evaluated at that time. Now, this is not statistically significant if you look at the p-values there, and this is an abstract and will be followed in manuscript later on. So when looking at BCR-ABL at least pH positive, and the role of TKI post-transplantation, this area has been debatable and talked a lot about because it's remember two things. We have the graft versus leukemia effect that is part of bone marrow transplant mechanisms in preventing relapse. But again, we know that TKI has been used for many times as some anti-GVHD effect. So this area has been always taught in the literature. But I had to go back to this review, and one of the approaches that, at least it has been discussed, this morning about the approach in pediatric pH positive ALL, that, we attempt to avoid transplantation unless you relapse or you have a persistent disease and high-risk PHA upfront by persistent MRD, and then you go for transplantation. And then, when you proceed to transplant, you're going to be MRD negative prior to that, and then you go for the transplant, and then after transplant, whether you initiate a TKI or not, and what kind of TKI. So, the senior author of this review, I've been looking at different studies, also transplanter, but as well as he's the one who's leading COG studies as well. And there are some recommendations, but otherwise it has to be really discussed. Older studies looking, especially in adults, there are multiple studies in retrospective manners, and they all show that preemptive versus prophylaxis. But there is some evidence that say post-TKI, both in pediatric and adult, has also some positive effect in preventing relapse. Now, to keep in mind also, many times we do not start those TKI until you have a stable graft. So when we look practically after transplantation, we look around 2 to 3 months post-transplantation. This is the time there's a good stable graft and you can initiate your TKI as well. So according to this review, that 17 trials showed that CR1 has improved overall survival. However, there was no benefit in CR2. But they are higher risk patients, so practically speaking, we were giving it more to the CR2 patients or all the higher risk patients. So the expert panel in this protocol mentioned that MRD assessment will play a role in initiating another kind of therapy. But again, it comes back to the same question: what is the method of measuring MRD post-transplant? And what is the MRD level that you would rely on? We already know that PCR, MRD post, even pre, is too sensitive for PCR able. So usually go with flow cytometry in general. And whether you use a TKI, if you have an emerging MRD, or use alternative things. In the past, we've been using DLIs, we withdraw immunosuppression, or do something else. So, if you are MRD positive, after transplantation, the recommendation was to do routine MRD assessment, particularly in the bone marrow, 1 to 1, 3 months, 6 months. Practically speaking, 2 months to 3 months is the time where you could see this emerging MRD. So some recommendation here say if you're MRD negative, you just need to monitor the patient, then you don't need to initiate prophylactic TKI, imatinib or bizatrib, at least in the pediatric setting. If you are MRD positive and you have a stable graft, then you would start a TKI. Most data and most centers will do imatinib because of the longer experience, as well as the narrow target. In addition, think that it has a little bit this side effects in terms of the bone marrow. The other point here is in regard to the alternative and when to use imatinib dosing. And it has been seen that the dose post-transplant, you may start with a lower dose compared to the one during the pre-transplant timing. Or you could just go and then escalate a little bit. So in summary, these are the things that I would like to summarize about TKI and what the conclusion we got. Although some people, we've been doing it sometimes prophylactically in high-risk patients to start with. But again, it is suggested here that you do the preemptive approach, and it's in MRD based. However, you see people have been doing different aspects. But we summarize that the impact of MRD pre-transplant is to lowest MRD, and we already agree about that. TBI-based regimen, and the method of MRD follow-up, particularly flow cytometry or an IGHTCR, but not the BCR-able RT-PCR because it's good. And for the duration and when to start, it's the preemptive approach that is suggested. And if progression happens, then you could do mutation analysis, which you don't see that in pediatrics as much. And then the dosing may require low dosing for those patients. I will not conclude about each slide because it has been discussed this morning, and the data is much less seen in pediatrics. Particularly on those PH like that, really the use of TKI is still in the time of discussion. On the other hand, if you look at other immunotherapies, so I'm not going to go and talk into depth into the blinatumomab, CAR-T, and natuzumab because each one of those had a different target and different approach. But we know that, for example, antibodies at that time of this slide, that it's at the front line or it's a relapse setting, we know the data now is pushing. But there were occasional studies here and there, at least in the adults, looking at the use of blinatumomab in the post-transplant if you have an emerging MRD. Now, this has been tested in very small in pediatrics, but you know there is always a risk of toxicity, yes or no, and all that. But this was an interesting study that was pulled recently in adults, comparing 19 patients who were receiving blina post-PAT compared to 39 patients who did not, with a different dosing. It's very short dosing, like 7-day dosing, etc. And it was very interesting to see that, although we cannot say anything, but in the future there might be some studies looking into that. It was interesting that in the control group, the overall survival is much less. You're comparing 100% in the intervention confirmed is around 60. But this is, again, it's too early and it's an adult data and need to be studied further. For the CAR-T as well, I mean, it's post-BMT. We don't do it unless there's a relapse, but those are the ones as well. In our hospital, National Guard Riyadh, we just initiated the program in 2023. We have done so far 15 pediatric patients. So far it's only 2 years, but the overall is running in the 75 and disease-free is 69%, but we are expecting that it may go lower further with the longer follow-up. Now moving to the last part in ALL for the K2 arrangement, I don't have also to spend time because this data has been presented in details this morning about the menin inhibitor and the recent data about the pre-transplant. But in this study, if we look at it, this medication is given as a continuous cycle, like at least 2 cycles, and there are dosing for pediatric, and it has a unique side effects as mentioned, like the differentiation syndrome and the cytopenias. This graph has been testing, and you see the initial response. But we don't know in the future of those patients will need this inhibitor after transplantation. I mean, in this study, it seemed it was allowed to use it after transplantation. The number of pediatric patients in this GCO application is much less than the adults, and there are different diseases at different ages. Some of them, less favorable compared to adults here, but this is different, and we're hoping to see, what the outcome of the COG current of the study, because that will help us in the refractory setting. But it might be something also to study, like post-BMT. Is there enough side effects, or is it something that could be considered to prevent relapse on those patients, especially that we know most of them are infant ALL, and if the infant ALL goes to transplant and they're a high-risk patient, there might be something to consider. Now we'll switch gear to AML, the heterogeneous disease with all the mutations at different targets. It was really discussed as well this morning, and looking at the risk and high risk. But I'll focus again, I mean, we have two targets, the FLT3 part and the KMT2A. So I'll focus more on the FLT3 part, and also it has been discussed this morning as well in regards to the type 2 inhibitors versus the type 1 inhibitor, especially if we have TKD mutation rather than ITD mutations. So in pediatrics, we use sorafenib all the time, but this is reflective of the adult data. The SURMAIN study which show the outcome of sorafenib versus placebo, where it is suggestive and confirmed the better outcome by using it, including it as a standard of care in adult, as a maintenance therapy most of the time after transplantation. However, as mentioned, pediatric is not always like the adult. And in the pediatric study, I have to mention also we have to worry about toxicity, because even in the adults, if we look at certain data, even in the real world data, post-transplantation using sorafenib has also some side effects, and many of the patients get discontinued and interrupted, especially when we talk about cardiac related side effects and cytopenias. This is one of the adult study that also look at the number of side effects or adverse events above, after giving sorafenib plus BMT. So high rate of interruption. Now in the pediatric age group, most of this data has been done as a retrospective manner and pulled from the studies, the series study 0531 and 1031, looking at the favorable outcome of sorafenib or FLT3 inhibitors in the chemotherapy preventing relapse, but also looking at the post-transplant patients' effect. And from most of those studies that was presented by Polarity Tal, the median age of initiating sorafenib was around 80 days post-transplantation. And the doses was variable. And you see there's a range from 1 month up to 2 years of giving sorafenib post-BMT. But there has been some toxicities and reduction and temporary discontinuation as well. But it has a very good effect. Now I must mention that it is expected in the coming EBMT, the EBMT is going to present the FLT3 inhibitor outcome in pediatric post-BMT as a registry study. So that will be available hopefully in the next month or two. Finally, I'll switch very quickly gears to post-auto high-dose chemotherapy transplant or non-transplant for the government. So we know for high-risk neuroblastoma that anti-GD2 currently is the standard of care, and that has been already demonstrated by the COG and the SIOP group, even without the use of IL-2. On the other hand, I have to mention that the data is emerging for haploidentical transplantation for neuroblastoma patients, and followed by anti-GD2. And this currently is being taken very, a lot of work by our colleagues in solid tumor group, doing whether the alpha-beta depletion technique and by the German group or the PTCY and by the Italian group, as far as I remember. And a lot of work also is going by the Italian group and the US group for CAR-T anti-GD2 patients. About Hodgkin, also just mentioning quickly, the data is emerging and it's changing, and the indication of auto is always a question. With time, we may see everybody is getting immunotherapy for Hodgkin, and hopefully we don't get those patients. But at least for the high-risk patient, especially in the adult group, the use of rituximab vedotin maintenance therapy after autologous shows up. So to conclude with the target therapy, I know it is very difficult to conclude by, randomized or prospective studies seeing the effect of those target therapy, because we are having a lot of options. But again, it's a patient by patient. We know that MRD assessment and in the future MDS will play a role. The target therapy, we have to tweak it based on patients. Who is the patient who's going to have a TKI or FLT inhibitor? Who is the patients who will get other kind of therapy, immunotherapy or directed therapy after that? So that's why hopefully individualized approach in cancer therapy, but also in transplant as well, is really the aim goal based on multiple factors, including the type of transplantation. And with that, I will conclude and thank you for listening.
So our last talk for this session will be live virtual with Dr. Christian Cavatini. Cavatini is joining us from Madison, Wisconsin. He's the chief of the Division of Hematology, Oncology, Transplant, and Cellular Therapy at the University of Wisconsin. Madison. He's Gene R. Finley, Professor of Pediatric Hematology and Oncology, and served as the acting director of the University of Wisconsin California Cancer Center. His research focuses on development and adaptive cellular therapy, CAR T cell and NK cells for treatment of childhood cancer, as well as macrophages for treating complications of bone marrow transplant. Nationally, Dr. Cavatini is an active member of the Society of Immunotherapy Cancer, where he recently served on the board as a at-large director. Additionally, he is a section editor of the Journal of Immunotherapy for Cancer, and served on the executive board for the pediatric chimeric antigen receptor consortium. So, Dr. Cavatini, sorry, we kept you late, but the floor is yours. And good to see you.
Cheers. Can you hear me now? Okay. Apologies. Assalamu alaikum. I want to thank the organizers for inviting me to speak at this meeting. I regret that I'm not able to attend in person and very much want to visit the holy city of Medina. The title of my presentation will be on usage of TCR alpha beta CD19 depleted haploidentical stem cell transplant with post-transplant zoledronate for pediatric malignancies. These are my disclosures. As background, as I assume most of you have not been to the University of Wisconsin in Madison, we have a very rich history in bone marrow transplantation. Shown here in the picture is Fritz Bach. who was the faculty member who developed the mixed lymphocyte reaction, or MLR assay, which was an important technology to allow, for the first time, potential matching of bone marrow donors. And in conjunction with the University of Minnesota, we completed the first unrelated bone marrow transplant and published back-to-back in the Lancet in the mid-1960s. Further research went on to show the important role of T cells in the graft versus leukemia effect in the 80s and 90s. And as was mentioned in the previous talk, we played a critical role in collaboration with COG in establishing rituximab anti-GD2 monoclonal antibody therapy as standard of care for neuroblastoma. And more recently, we had the pleasure of serving on the phase 2 Al-Madinah and Ensign clinical trials that established tisagenlecleucel or Kymriah as standard of care for relapsed refractory pediatric leukemia. And I was fortunate to be the site PI for those studies. We continue to have leadership in COG and have the honor of serving for the last 12 years on a pediatric cancer dream team shown here on the map. This is a team that we share with 9 other hospitals in the US and Canada, all committed to doing advanced bone marrow transplant and cellular therapies for pediatric cancer. We are also a member of the NCI Cancer Immunotherapy Trials Network and NIH providing Moonshot Initiative. We offer MIBG therapy, and I'm proud to say have the most clinical trials at our cancer center. For today, we're going to talk about one of our investigator-initiated trials. As mentioned, the haploidentical stem cell transplant and post-transplant zoledronic acid. But we do have a variety of other cellular therapies available, many industry-sponsored, and this year we'll be launching investigator-initiated trials with CAR T cells. We also are one of the few sites in the U.S. that make GMP-grade radioisotopes, and so offer a variety of theranostic studies for pediatric solid tumors beyond MIBG. As all of you well know, outcomes for relapsed pediatric solid tumors remain very poor. No matter what solid tumor you look at, those patients with metastatic disease have outcomes that range anywhere from as low as 25% to neuroblastoma, which hovers closer to 50%. But for many of these diseases, advances in therapy have not led to improved outcomes. And in some cases, we've been using the same chemotherapy drugs for the last almost 50 years. For some diseases, allogeneic stem cell transplant has been tested. In this slide showing for high-risk neuroblastoma, this is data from the CIBMTR, the International Bone Marrow Transplant Registry, using allogeneic transplant after autologous transplant or as standalone therapy. In both cases, it was unsuccessful, mainly due to disease progression, implying there's not a graft versus tumor effect, but also because of complications like graft versus host disease, which can be lethal. So the question for today's lecture is how do we optimize transplant to minimize GVHD while enhancing graft versus tumor effects, the so-called Holy Grail. At our center, we've adopted alpha-beta T-cell depletion as a mechanism to offer allogeneic transplant to pediatric solid tumors. As you know, this technology involves using magnetic cell selection to pull alpha-beta positive T cells and also B cells using a magnet from a peripheral blood stem cell graft, which effectively enriches the graft for innate lymphoid cells, such as gamma delta T cells, NK cells, and of course, stem cells. This technique was developed in vitro by a former faculty member, Mario Otto, in a paper in cytotherapy while he worked in Rupert Angreicher's lab in Tübingen, Germany. About 8.5 years ago, we treated the first child with this approach with a solid tumor in the United States. And this child, the first patient, remains a long-term survivor with the help of post-transplant dinutuximab given off-study. The process for performing alpha-beta depleted transplant involves leukapheresis from a haploidentical donor. Typically a parent is selected, but we have also offered it to adult siblings. The donor is given GCSF to mobilize CD34 positive cells, and these are collected as an outpatient through leukapheresis. Using a Clinimax system, the alpha-beta T cells and the CD19 positive B cells are depleted, and that enriches the stem cell product for the stem cells, gamma delta T cells, and NK cells, as well as monocytes. The products are then administered as a fresh product back to patients who have been conditioned in a couple of different preparative regimens. Prior studies by 3 groups have shown that alpha-beta depletion in children, at least with leukemia, is safe and effective and enriches for innate lymphoid cells. First, I'm showing you data from a Russian group that was published in 2016, showing that both for patients who go into transplant in a CR, as well as with detectable disease, you can get respectable outcomes. This was corroborated by the Tübingen group in Germany, who also showed that gamma delta T cells peak at about 2 weeks after transplant, and slowly alpha beta T cells, while depleted, do recover, but can be as prolonged as 6 months to a year. Importantly, the Alice Britannia and the Italian group showed that the outcomes of haploidentical transplant using this platform are no different than using a matched sibling or a mud transplant. But importantly, they found that, at least in patients with leukemia, giving a myeloablative regimen with total body irradiation had better leukemia-free survival than reduced intensity conditioning regimens that were chemotherapy-based. Given this information, we opened a single-center, open-label, single-arm, ongoing phase 1 clinical trial for children between the ages of 6 months to 21 years. To be eligible for the study, you had to have relapsed or refractory hematologic malignancies or high-risk solid tumors. That could be metastatic or relapsed refractory. We tried to pick the parent who had the best cure-cure ligand mismatch, although it was not required. We offered 2 different conditioning regimens. All solid tumor patients received a reduced intensity conditioning with ACG, fludarabine, Viatepa, melphalan. Based on the Italian data, we allowed patients with leukemia to receive a total body irradiation myeloablative regimen, as long as they had not received a prior transplant that included TBI. But given the 3 prior studies I had shown you had done alpha-beta T-cell transplant, none had tested them in patients with solid tumors. But we didn't think the transplant alone would be sufficient in that population. Here I'm showing you the chemical structure for zoledronate, also known as zoledronic acid. This is a 3rd-generation bisphosphonate molecule that is approved to treat osteoporosis as well as bone metastasis for a variety of cancers. It works by inhibiting osteoclasts, thus promoting bone generation. It turns out that gamma delta T cells express an aminobisphosphonate receptor on their cell surface. Given that B cells are thought to be enriched after alpha beta T cell depletion, we wanted to test if using this drug would become a form of doing in vivo gamma delta T cell activation and expansion. This was based on prior published data from the Italian group showing both in vitro in 2015 that zoledronate can stimulate degranulation of lymphocytes and specifically of the V delta 2 population, which is thought to be the graft versus leukemia reactive innate immune cell subset. They also tested in vivo in patients with leukemia who got post-transplant zoledronate and found that those patients that were alive after the study had higher percentage of V delta 2 cells than those patients who were not alive. And in general, they found that receiving 3 or more doses of zoledronate was associated with better survival. So our study was going to both validate those results, but also for the first time examine it in children with high-risk solid tumors. We proposed giving 5 monthly doses of zoledronate starting on day 28. We would have preferred to have given the zoledronate earlier since we know gamma delta T cells peak at day 14, but the FDA was not comfortable with us doing that so as to not interfere with engraftment, potentially. As a result, the study ended up evolving with different arms unintentionally. When we first opened, zoledronate had never been given to children post-transplant, so the FDA asked the first 3 patients to not receive any zoledronate, which in effect served as an internal control. Then the next 3 patients were allowed to get 2 doses of zoledronate, and then every patient since the 7th patient gets 5 doses of zoledronate. But again, conditioning regimen dependent on the disease enrollment. In total, we've treated 14 patients on the study. You can see from this table that it's been a wide variety of ages, as young as 3 years old and as old as 18 years old. We have an equal mix of males and females. And importantly, we have a nice distribution of solid tumors as well as leukemia patients. 8 of the 14 children that enrolled had high-risk solid tumors. The solid tumors that we treated included neuroblastoma, rhabdomyosarcoma, and osteosarcoma. This slide shows the summary results from these patients. On the left, we show the swimmer's plot for the 7 hematologic malignancy patients. Many of them were treated in a CR, although you can see one patient was in a PR at time of transplant and converted to a CR. Importantly, we show that the CR is maintained post-transplant. On the right-hand side, we see in solid tumor patients a combination of disease states. In some cases, patients came in a CR and the transplant served to consolidate the disease. And again, even though they were highly refractory to chemotherapy, they maintained their CR post-transplant up to a year. Many patients with neuroblastoma decided to go off study voluntarily to receive dinutuximab treatment post-day 100. As I mentioned earlier, 2 of those patients are now alive 8 years later with no further therapy. And of note, those patients had received dinutuximab as upfront therapy and had progressed. So our belief is that by replacing their immune system with their parents' healthy immune system, they're better able to respond to anti-GD2 therapy. We also saw CRs in patients with rhabdomyosarcoma, but we also had patients with both neuroblastoma, osteosarcoma, and neuroblastoma that progressed on therapy. In summary, 10 of the 14 patients in a CR or converted to CR, which was a 71% rate. We did see some GVHD, including one case of grade 4 GVHD, with a total acute rate of 21% and chronic GVHD of 7%, but all cases were treatable and resolved. So no patients died of GVHD. You can see that the overall survival for these very high-risk patients, which we would expect to be between 25 and 50%, ended up at 60%. And you can see that in total days since transplant, we're approaching 3,000 days. And there didn't seem to be a difference whether you had a hematologic malignancy or solid tumor. We did look to see if the number of doses of zoledronate influenced outcome, and we found for sure that if you got only 1 or 2 doses, all of those patients died. However, we cannot credit the zoledronate, as patients with no zoledronate did as well as patients who got 3 or more doses. What we did find was that the patients who had cure-favorable donors had statistically significant improved survival than the patients who did not have cure-favorable donors. So we took a deeper dive using correlative biology and found that those patients that received zoledronate had enhanced expression of KIR2DL on their gamma delta T cells. In addition, we did plasma cytokine analyses and found interferon gamma was elevated on days 28 and at 12 months post-transplant in those patients who received zoledronate versus those patients who did not. To our surprise, we did not see the impact of zoledronate on the number or activation of V delta 2 gamma delta T cells as others have seen in their leukemia studies. In contrast, we noted that zoledronate increases the number of cytotoxic NK cells as defined by CD56-DIM, CD16 positive. We also saw that the number of activated NK cells went up as defined by CD69 positive. In conclusion, I've shown you that TCR alpha beta CD19 depleted haploidentical stem cell transplant is feasible and safe for children with high-risk cancers, including solid tumors, where I would argue most physicians do not offer allogeneic transplants. We know that it can maintain or in a couple cases induce remissions that can last years. Some patients may need post-transplant immunotherapy to achieve that. There's low rates of GVHD, but it's treatable, and favorable overall survival is noted, especially if you have cure-favorable donors. We also learned that zoledronate can be safely administered after TCR alpha beta transplant. It induces KIR2DL1 expression on gamma delta T cells. It augments interferon gamma levels and increases total inactivated NK cells. We recommend that multi-center studies of this platform with post-transplant zoledronate are needed in pediatric solid tumors. And we are in discussion specifically with the COG neuroblastoma group in trying this approach in that population. I want to acknowledge our funding sources shown on the right, as well as the members of my lab as shown in red who contributed to the correlative biology studies. This work was pioneered by Mario Otto, who I mentioned earlier, worked in Rupert Eckreichen's lab in Germany, but left our program to be division chief of pediatric hematology oncology at Phoenix Children's Hospital. And I am now sponsor and PI of the study. And I want to thank my other colleagues who have contributed to the work and will take questions. Thank you for your time.
Thank you for all speakers. May I ask the speakers, Dr. Ahmed, Dr. Lisa, Dr. Khalidi, kindly stay with us for any questions or comments. Dr. Ahmed, please. Yeah.
you for all speakers. My question to Dr. Ali about consolidative stem cell transplant post-CAR T-cell. So what are the factors that you put in mind taking patient to consolidative transplant? I know that transplant naive, but mostly you will not find a lot of them. So what are factors that you put to consider transplant?
Thank you. It's an excellent question. In our hospital, probably in our country, we don't have the tools really that can predict relapse, as they have shown that they are using NGS MRT, which is 10 to the power minus 6. So with that tool really, it's easy to predict the relapse. Those more than 0 MRT, they should go for stem cell transplantation. And those actually negative MRT have excellent survival, more than 70%. So unfortunately, we've been short of this sensitive tool. Any naive, transplant naive patients, we are taking them to transplant immediately, 2 months to 3 months post-CAR T. The problem with those subgroup that already have transplanted before, so we are monitoring based on flow-based MRD plus B-cell aplasia. So we would reassure with more B-cell aplasia. However, cannot predict the relapse because they can relapse as CD19 negative relapse. And we have seen relapses. CNS, isolated CNS, initially we have seen that better survival for isolated CNS, but lately we have late relapse for those. So this is the approach that we are using now. Hopefully, I think by adopting NGS-based MRD, we can predict those patients.
May I ask Dr. Ahmed a question? Well, very impressive, and we are very proud as Saudis and for the country for the rapid progression and execution and completion of the CAR T cells. So, in your opinion, as the founder of this or the supervisor at the beginning at King Faisal Riyadh, so when do you see that this kind of fancy novel therapy will be readily available in multiple centers across the country, those with bone marrow BT setting, and what might be the major limiting factors for conducting this in multiple centers for CAR T cells?
I think it will come. Most of the centers are actually very well equipped. Any transplant center can do. But if your questions regarding the development of CAR T, I mean viral vector manufacturing, this is the thing. If you can see CAR T, most of the work really in manufacturing the construct, which is more than 70% of the work. So this is, we still did not have this so far. Hopefully, our research centers here in the kingdom will go and invest really money and time and people in working at this type of CAR T cell therapy. I'm aware that at the highest level now, and the vision for CAR T cell therapy in the country are planning really to go to that goal and achieve complete manufacturing of CAR T cell in the kingdom. And even now, I think they attract big pharma like Novartis, and probably they wish to sign MOU with Novartis and other companies for building manufacturing of CAR T cell therapy here in the kingdom. Probably in the coming maybe 3 to 5 years, we are going to see this in reality. So there is a big vision and strategy in localizing CAR T cell therapy manufacturing and also gene therapy.
Questions?
Dr. Shahar, question for Dr. Muhammad. What are the most challenges that you are facing for patients related to target therapy, patient going for transplant? This is related to the test, related to the medication availability. How do you help and solve this problem?
Thank you, Dr. Ahmed. Yeah, the challenges is to general is to make the personalized approach on things. In terms of target therapy, it depends what you're talking about. But the good thing about TKIs and the FLT3 inhibitors, they're already available because we're in the hospital also where our adult colleagues also have a lot of patients of AML. So we have access to those medication. However, the second and third generation, because of the limited data, we have sometimes, for example, I have a patient with TKD mutation, and I had to adjust and call different people to get the microsatellite at that time to give it for a patient. It was an adolescent patient, so it was okay to start this medication. But this is one of the area of challenges that we have to fill in formulary forms to give this kind of medication, and then later on it goes to our administration by the clinical pharmacist. So this is one of the things, the challenges. The other two challenges in regard of target therapy in terms of those TKIs and others is the MRD assessment versus full chimerism assessment after transplantation, which it's a little bit different than the other approach. We use flow cytometry, and there are other alternatives like capillary immunosuppression, give a DLI, and then later on institute, make sure that the graft is functioning before initiating those medications sometimes. So this is the main two challenges. But in regards to other target or like immunotherapy, it's currently we are evolving, they are accessible. We do offer CAR-T, blinatumomab easily for patients who require those kind of therapy apart from transplantation.
Okay, it is, if no questions, because it's 10:50 now, we'll conclude the session. Thank you very much for. So we have one last question. Yeah, please, Dr. Inata.
I appreciate that you have quite responsibility after the transplant. Do you see any calcium issues or the low calcium issues? And also in this platform, it is also possible to add some additional maintenance therapy, such as B7, RINA, or neuroblastoma, something. I don't know, GDP can be added. I don't know, this additional augmentation can be considered on top of this possibility. Just curious.
Those are great questions, Dr. Inaba. We have not seen any lasting hypocalcemia because we put patients on vitamin D and calcium carbonate preemptively. Sometimes we have to increase their dose, but they've not needed inpatient treatment for hypocalcemia. And so it's very well tolerated, and we give it as an outpatient infusion for as long as they tolerate. But for your second question, that's an absolutely great point. And I think that we can couple zoledronate with other therapies, either targeted therapies or immunotherapies, because it is so well tolerated. And certainly future iterations of this study will test those concepts.
Thank you, Dr. Katini. So my question, were any of the neuroblastoma patients pre-treated with MIBG, the one transplanted in the study?
Yes. We did have at least one patient who was on a COG protocol for upfront therapy where MIBG was given as part of induction therapy. But this patient, unfortunately, was not one of the survivors. But I believe the patient received only 2 doses of zoledronate and then rapidly progressed.
Question is to Muhammad and Dr. is about the neuroblastoma and immunotherapy. How far you go with the immunotherapy post, for example, MIBG and stem cell rescue. What is your criteria to consider haplo after immunogen therapy? Would you use it for palliative intentions? So far, we don't have the technology for the haploidentical transplants. We just keep going on with the immune therapy, which actually has a very good impact on the quality of life for patients.
Yeah, those are great questions that need to be sorted out. I don't think we really know how long to give post-transplant immunotherapy, either in the haploidentical or any transplant setting. Obviously, after autologous transplant, it's used as for 5 cycles of maintenance therapy. Remember that there are now multiple anti-GD2 antibodies to choose from. Dinutuximab is approved in the US, but dinutuximab beta is approved in Europe. We're the only site in the US testing this agent in our minivan study, and we have found that it's much more tolerable and can be given as an outpatient treatment. There's also the naxitamab therapy that was approved out of Sloan Kettering, but we've not widely used that medication due to the fact that it requires much more treatment for pain. But all of these agents still require further testing to determine how long they need to be tested in the post-transplant setting.
Okay, with this, we'll come to the conclusion of this session, and thanks for the speakers and for all of the audience. So we'll break now, and we'll be back exactly at 11:10 this morning. Please. Thank you.
السلام عليكم ورحمة الله. والله شكرا.
Check. 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 Bismillah ar-Rahman ar-Rahim. Check. Bismillah. Check.
Al-Madinah Al-Munawarah, organized by King Faisal, branch of Al-Madinah Al-Munawarah. The colleagues who are in the organizing committee had put a good program, as I can see, which attracted the audience even when we are today, Friday, and we see a good number of attendees. That means the program is quite attractive and well prepared. It's my pleasure to be here as a co-chair for this event. I'm consultant in hematology and oncology, King Faisal, Riyadh. And it's my pleasure to co-share it with Dr. Ahmed, consultant in hematopathology and head of hematopathology in the Department of Pathology and Laboratory Medicine in Medina. Ahmed is starting a good service in Medina, and I think we start to see the outcomes of what he had established as a diagnostic, including something we will be talking about today. The other co-chair is a famous guy who's known everywhere, from adult side, from pediatric side, heme-onc everywhere. Dr. Mohammed Al-Shafani, the chairman of the Saudi Society for Bleeding Disorders, and he's a consultant in pediatric heme-onc, and has a history long history of treating patients with various oncology, pediatric oncology disorders. I will not take longer time. I would like to invite Dr. Mohammed to introduce first the speaker.
Thank you so much for this nice introduction. And indeed, I would like to thank the organizing committee and scientific committee, Dr. Al-Madinah and Dr. Muhammad and Dr. Ashana for inviting me to participate in this session on oncology. So thank you so much. I am proud to be here. It's my great pleasure and honor to introduce Professor Faisal Justiniya. I'm sure everybody knows Dr. Faisal locally, nationally, and internationally. Highly respected experts in the field of pediatric hematology oncology and bone transplantation. He is a professor and consultant in pediatric hematology oncology, and currently he serves as the chairman of the oncology department in the Special Hospital and Research Center in Jeddah. His contribution to the field, particularly in pediatric hematology, sickle cell disease, leukemia, and cancer predisposition syndrome have been truly remarkable. Beyond his professional achievement, Professor Justiniya is also a member of the SAPS group, a chief contribution to advancement in pediatric hematology across the region. On personal note, he is not just an esteemed colleague, but also he is a good friend, his family, doing this for health standard and quality that make him stand out, not just as a physician, but also as a great person. So he's going to talk about the advanced and measurable residual disease, MRD. So please join me to welcome Faisal.
Thank you, Dr. Mohammed, for this warm introduction. And Assalamu alaikum all, good morning, and it's really a pleasure to be here, and I'd like to thank the organizers, and special thanks to Dr. Afshan, Dr. Mohammed Sayyid for their kind invitation, and congratulate them on this second year in a successful conference. Dr. Mohammed, when he talked to me about giving a talk, he assigned me this title, Advances in Low Measurable Residual Disease, or MRD. And I'd like to disclose before I start that I'm not a hematopathologist, I'm not an immunologist, and I'm not a molecular geneticist. So if you share my background, this talk is for you. For the others, I'm sorry. I have to go and hear it from a non-expert in the technical side of things. But what I'll try to do is answer some of the clinical relevant questions, and I've put three main questions to address during this talk. We know that minimal residual disease or measurable residual disease is one of the advancements in precision medicine over the past 2 decades. And it's been shown that MRD is prognostic. However, in the era of precision medicine, how precise is MRD? What is the positive predictive value, the negative predictive value, the likelihood ratios of predicting relapse or recurrence? The second question is, does MRD now really inform decision making? Does a negative MRD make us able to reduce therapy and maintain survival outcomes? On the other hand, what was the positive MRD, intensifying therapy for positive MRD, will it improve outcomes in particular? And I'll then highlight on some of the limitations and challenges and what is next to address some of these challenges. So looking at the first question, this is a study that was recently published that looked at all the literature in the past decade that addressed MRD. And from this study, they were able to compute and analyze the positive predictive values and the negative predictive values for MRD in predicting relapse and recurrence. And as you can see, for hematological malignancies, the positive predictive values was 55%. And for a negative predictive value, it was 77%. When you go to solid cancers, the positive predictive value from looking at circulating tumor DNA or cell-free DNA or residual disease by blood testing was 75%, while the negative predictive value was 88%. When they looked at the likelihood ratios or the odds of likelihood of relapse in an MRD positive versus an MRD negative patient, you can see that, again, for solid tumors, the odds ratio is higher at 9.1, while for hematological malignancies, it was 3.5. And within the hematological malignancies, AML tended to have a higher odds ratio of 4.7 compared to ALL with 2.5. They then sub-analyzed different characteristics that are related, that predict the odds ratio for MRD positivity and relapse. And they noted that it's not only the disease, but also other factors such as MRD timing. Later MRD positivity tended to have a higher odds ratio of relapse, and also the type of testing. So MRD testing sensitivity also related to the odds and likelihood ratio of relapse. And that brings us to the current tools and sensitivity of the current tools that we have today. So today we have 4 different ways of measuring MRD, the traditional conventional method of morphological assessment, multi-flow cytometry, real-time and digital PCR, and next-generation sequencing with or without error correction. And based on these tests and these sensitivities, we can now classify residual disease into morphological residual disease, measurable residual disease, non-quantifiable but still measurable disease, and with the current tools that we have today, there are still a non-detectable disease. Whether this will be also detectable in the future depends on how advanced our technology proceeds and progresses in the near future. The important aspect is what really matters. Does sensitivity really matter? And the type of testing, does it really matter? And I think a lot of the lectures early in the morning alluded to this. And this is one example of a children's oncology group study that looked at children with AML, the 0531 study. And in that study, they looked at morphological assessment of remission compared to flow cytometry assessment of MRD. And then what they've shown is that those that had a morphological disease or those that didn't have morphological disease, both of them had positive and negative, false positive and false negative MRD when measured by flow cytometry. And what they concluded from the study is that flow cytometry was not only better in predicting survival outcomes in AML, but also that lack of morphological response was a false positive in almost a third of patients when compared to MRD by flow cytometry. A similar study, or another study, this is an adult study that looked at next generation sequencing versus multi-flow cytometry. And what they found in this study is that measuring MRD by next generation sequencing did add to the prognostic value of patients with AML. So patients that had negative MRD by both NGS and flow cytometry had the least cumulative incidence of relapse, while those that had positive by both methods had the highest risk of relapse. Those that were discordant had an intermediate risk of the relapse, and they concluded that NGS and multi-flow cytometry had an independent and additive prognostic value. This is a similar study, but in pediatric ALL, B-cell ALL, again from the COG standard risk and high risk trials, the 0232 and the 0331. Again, looking at paired samples that were tested by MRD by flow or by clonoSEQ for high throughput sequencing through the next generation sequencing. And again, they showed a similar kind of finding where sensitive methods identified more positive patients, MRD positive patients. In fact, high throughput sequencing identified approximately 39% more patients that were MRD positive. More importantly, those that were throughput sequencing negative and MRD negative by flow had the best survivals, while those that were MRD negative by flow but positive by high throughput sequencing had a inferior survival compared to NGS negative in B-cells with AML. So sensitivity of the test implies prognostication. However, should we use MRD to inform treatment decisions? Unfortunately, we don't have a well-designed trial that asks this question in particular, but we know of different patient populations that are positive and negative that were treated with different methods and stratification to answer this question fairly, and most of the randomized clinical trials are in ALL, but I'll touch base on some of the selected studies that may help answer some of these questions. So first, is reducing intensity of treatment feasible in MRD negative patients, and second, would intensifying treatment for MRD positive patients improve outcomes? So this is the first question, so reducing for MRD negative. So if you look at the right side, this is the UK ALL 2003 study that looked at treatment reduction by eliminating or reducing one cycle of delayed intensification versus the standard at that time. And they showed that treatment reduction is feasible in MRD low-risk patients with no non-inferiority to the standard arm at that time. On the left-hand side is the more recent COG study that looked at intensifying versus keeping low intensity therapy for a favorable risk group that was also identified by MRD negativity through flow and NGS. And they showed that standard therapy without intensification cures nearly all children with low risk ALL, and you can see the impressive survival curves almost extending from the 100%. How about in AML? So this is another COG study that looked at eliminating one cycle of therapy compared to standard, so reducing it from 5 to 4 cycles of chemotherapy. And they analyzed patients that received 4 versus 5 cycles, subgroup by MRD at end of induction 1. And you can see in the top figures that those patients with low-risk AML that had an MRD less than 0.1% after induction 1 had similar survivals when they took 4 cycles versus 5 cycles of chemotherapy. However, those that were MRD equal or above 2.1% had an inferior outcome when 4 cycles or 1 cycle was eliminated. Again, showing that MRD may inform the treatment intensity in some populations of patients. The second question is increasing treatment intensity for MRD positive. Does it impact outcome? And again, this is the same study, the UK ALL 2003, that looked at augmenting therapy for patients that had an MRD 0.01% or greater. And you can see that those that had augmented therapy in the blue Kaplan-Meier curve had a significantly better survival compared to standard therapy. However, this was associated with more adverse outcomes, more adverse events compared to the standard therapy. More recently, I think you've seen this study a number of times during this conference, is the 1731 that introduced blinatumomab before and after interim maintenance for patients with standard risk average and standard risk high patients. And that study showed that the addition of blinatumomab significantly improved survival outcome. Or for the sake of this talk, I want your attention to the red box here, that this also impacted patients that are MRD positive by flow or NGS, eliminating the significance of the positivity of the MRD when blinatumomab was added to this backbone. This is a study on AML in adults that is not a randomized controlled trial, but this study was from China, but was published recently in the JAMA, and looked at a registry-based cohort study that analyzed the dynamics of MRD after 1, 2, and 3 courses of chemotherapy, and stratified patients based on the treatment that was received, whether chemotherapy, autologous, or allogeneic transplant. And they were able to group patients into 5 different groups. Those that were MRD negative at 3 time points had similar outcomes if they received chemotherapy versus allo versus auto. However, those that had positive MRD after one cycle, after MRD time point 1, auto and allo were similar, but better than chemotherapy, and if you had MRD positivity after time point 2 or time point 3, or recurrent MRD positivity, then allotransplant was superior to other forms of consolidation therapy. So they concluded from this study that clinical decisions based on dynamic MRD might be associated with improved therapy stratification to optimize post-remission therapy. So in the era of precision medicine, is this precise enough? Yes, there is a notion that this may help in deciding and stratifying and intensifying therapy, but is it precise enough? And the answer is that we still have limitations. There are challenges and limitations related to sampling and technical limitations related to phenotypic shifts and genotypic clonal evolution while on treatment. And there's assay limitations for each test method. There are advantages and disadvantages. But there's also analytic challenges. We tend to oversimplify MRD by putting fixed thresholds, ignoring the different kinetics of MRD in different subtypes of cancer, or by categorizing patients into positive and negative, or trichotomizing patients into below, between this fixed level and this fixed threshold, or above a certain threshold. Biological variability and obviously competing risk in analyzing survival outcome is an important consideration that may complicate the MRD results. And these are just some examples of some of these limitations and challenges. This is a study that looked at genotype-specific MRD in pediatric ALL. And if you look at the right-hand side, these are the different, all patients grouped together, B-cell ALL, almost 2,500 patients. And at the bottom is the T-cell ALL. And this curve shows two important messages. One is the dynamics or the density or the frequency of clearing MRD is different between genetic subtypes of B-cell ALL and also phenotype. And also the risk of relapse as color-coded in a heat map at the end of the slide is different by genotype and phenotype as shown in the figure. And this study showed that the risk of the relapse, although it was directly proportional to the MRD level within each genetic group, the absolute risk of relapse was associated with a specific MRD varied by the genetic subtype. This is a study by Dr. Hiruto and the St. Jude group that showed the contrary, or a different point that is important to mention is that when measuring MRD molecularly, some genetic subtypes remain persistently positive by molecular methods, but negative by flow cytometry methods. And in this particular core binding factor subgroup, this persistent positivity by molecular methods did not really translate into increased relapse risk, again showing the limitations that we may have. So really, not everything that can be counted counts. And you have subclonal limitations. You may be counting the subclone rather than the original leukemia-initiating cell, or you may be counting clonal hematopoiesis or germline mutations that may be overrepresented when looking at different genetic sequencing modalities. And one way to overcome this is to do different testing. This is a study in adult AML that added an extra tube in this trial for leukemia stem cell measurement. And they've shown that the leukemia stem cell load, when combined with the MRD load for AML, may be additive and informative. Again, the same phenomena that's seen by NGS, but here this is by flow. So leukemia cell negative and MRD negative have the best discordance, have the intermediate, and both positive have the worst. So what's next? How can we overcome these limitations? And I'll touch base really quickly for the sake of time. So we can either enhance flow cytometry by enriching using cell sorting. We can try out new tools of measuring circulating and cell-free DNA is another method to increase the sensitivity of detection. The single-cell technology now is a hot topic, and we've seen a lot of papers showing that this integrated approach may be more informative. And with the advances, we hope that maybe we can eliminate the need for bone marrow and monitor through blood testing, and hopefully in the near, not very far future, maybe MRD can be a point of care testing with more dynamic measurements of MRD even at home that will be more informative and help us really reach that precision medicine approach. And this is just showing some examples of these methods really quickly. This is from Germany, where they enriched samples of CD34 enrichments using cell sorting, and then the NGS measurement in post-transplant patients. And they've shown that the combination of cell sorting and CD34 was superior in detecting 1 in a million cells in these patients. And this is the liquid biopsies showing that you can detect circulating tumor DNA and cell-free DNA before blasts are detectable in the blood. And this is a study that showed the same thing, that in the red line on the right, you can see that cell-free DNA appears earlier than blasts in the peripheral cells. And this is another in B-cell ALL that showed that next generation and high DNA inputs can identify more positive MRDs that were previously missed in the peripheral blood, implying whether we can really eliminate the need for bone marrow in the near future. Lastly is the single-cell sequencing, where you can joint or integrate genotyping and phenotyping to have more informative and more relevant MRD testing to differentiate between clonal hematopoiesis, resistant cells, and evolving molecular or genetic abnormalities as treatment goes on. And this is in a pediatric setting with pediatric AML, again, that showed residual cells can be detected by using ultra-deep sequencing and single-cell multomics that can inform the more relevant residual leukemia cells that can be targeted by different therapies. So the future is really near, but we need to do a lot of analytic standardization, technical optimization, clinical validation, and learn how to integrate this in precision medicine today. And with that, I'll conclude, and I'll remind you that, yes, if you can't measure it, you can't manage it. However, remember that not everything that can be counted counts, and not everything that counts can be counted. Thank you very much.
So we will move to the next presentation, which will be
Assalamu alaikum. I have the pleasure to introduce our famous pathologist. Dr. Muhammad Al-Halim is a hematopathologist. He's also a molecular biologist and an immunologist. He did his master's and PhD at University of Manitoba before serving as a head of flow cytometry at Dalhousie University, Halifax, Nova Scotia. Currently, he is at the Hospital of Sick Children in the University of Toronto, serving as a hematopathologist, molecular biologist, and immunology. Without further ado, please, Dr. Muhammad.
Thank you very much, Dr. Thank you for the multimedia team getting nice picture. It's a surprise. When Dr. Muhammad asked me to give a talk, I just chose this sort of like a general title. what else can I add to this at the end of it? So I think what I'm going to be doing is just share with you some high-level personal thoughts and experience and how I see from the clinical laboratory point of view the field has changed over the course of my term serving at CKS for a number of years. There is no better model to discuss advances either in diagnostics or in therapy than acute lymphoblastic leukemia. So this would be the main. So in the clinical laboratory, we are sitting in the middle between the POSS. The POSS has an objective that is disorderly proliferation that is uncontrolled. And in the lab, our task is basically to generate, integrate, and communicate precise information in a tightly controlled setting. Now, I'm highlighting precisely because in my other talks I use relevant information, but this is precision medicine, we use the term precise here, but it's the same. And we provide that information to the clinical team whose objective is to safely introduce obstacles to prevent the blast from achieving its goal. That's basically what the clinical teams do. So, laboratory advances, you can look at them in several ways. But they have been driven by advances that are interplay between the basic science and, again, as a model of the complexity in cell biology, there is no cell better than the lymphocyte. That. And advances in translational research that takes the basic science and changes to make them possible to become a diagnostic test, and then finally advances in the clinical trials that transforms a study question into a standard of care. And then you can look at advances in terms of degree, so you can have multiple colors for flow cytometry. You can have advances in kind, which type of analyze that you are using, and you can have a disruptive advance, and that disruptive can result from a change either in the concept or in the tool, meaning the analyzers that you can use. I'm going to go very briefly through 5 areas that cover the practice of the clinical. The first one is a digital morphology. Counting and describing leukemia blasts from the 17th century hasn't changed. We just need to count them and we need to describe them. The digital microscopy has actually allowed 2 major areas of advances. One is that remote access. You can actually share images and do your work remotely. And you can actually enhance the morphology by introducing digital tools to identify, classify, and integrate things. The second modality that we use after we look at the shape of the cells, we look at their structure at the level of the protein by using flow cytometry. In flow cytometry, you can be just summarized as different colors, different tones, and advanced computing. So the more flow clones that are available, clones right now, either antibody or metal ions, advanced computing that will introduce artificial intelligence to allow automated and so on. A major advance has been happening in the development of optimized flow cytometry panels and also in standardization of the panels. Here I have to mention the efforts that is done by the Euroflow group that has become pretty much an international standard in terms of authorization. But in terms of standardization, here we have to really be careful when we are discussing highly sensitive tests such as a measurable disease. One of the advances in children's oncology group is that the standardization of flow cytometry testing in a clinically testing fashion. I mentioned that artificial intelligence is now used in automated analysis and Euroflow has that. And by far, the most advanced over the last couple of decades has been the shift in leukemia from the phenotype to genotype. And studies that have started at the turn of the century and St. Jude's by Jim Down and later on by Charles Mulligan. Initially, the expression microarray has been introduced as a platform that can be a unified. It didn't materialize as a clinical test, but it actually opened the field, and then followed by the next generation sequencing, where right now, you don't have only to look at T or B, but you need to classify the precursor B into several genetic subtypes based on the chromosomal numbers, chromosomal structure, the type of translocations. There are so many of them right now, and they are pretty much grouped under the biological physical pathways such as sequencing, transduction, protein modifiers, transcription factors, and so on. So that has all been covered by the talks. Now, what I really want to spend some time on, and it has been touched to us in the discussion about single cell. Now, we have been using single cell analysis in morphology because in pathology we are single cells. We are looking at one cell at a time. Flow cytometry, same thing. We are writing ourselves as flow cytometrists, that means analyzing one cell at a time. Interrogated by the laser beam and then investigated one cell at a time. But until recently, sequencing was bulk sequencing. We were not able to do sequencing at a single cell level. So the molecularization of single cell analysis is happening, but not only measuring one layer within the cell, but you are able actually to look at multi-layers, which are described as single-cell multi-omics. So these layers that we can look at within the cell involves the genome, the DNA, which is the blueprint, and then after the genome there are modifications in the DNA at the level of methylation, which allow control the transcription of genes, but also the level of the DNA associated proteins like protein modifiers and installing post-translation modifications. And then after the genomic layer, the epigenomic layer can actually test the transcriptome, which is RNA molecules described from the genes. And then after that, the proteins that are translated from the transcribed genes, and then finally we can measure the metabolic products within the cell. So these are the layers of omics that is being investigated right now in the translational and transitional stage before we reach into the clinical laboratory. And that will allow us to examine intermolecular dynamics in a single cell. And to be able to do that, we have to isolate single cells. We have to uncover the RNA from DNA before testing. We have to combine them again. And possible combinations that have been tried include testing DNA methylation together with the transcriptome, testing chromatin accessibility and gene expression, testing the transcriptome and proteome at the same time. And after testing, we need to integrate these data, and then we have a downstream stream analysis and visualization of the data. So that field that is moving now, as I mentioned, into the translation of the state within traditional clinical lab, as of yet is faced with challenges, including a incomplete capture analysis. One of the problems with that is that you might not be able to capture all the data at the same time. Disparity in the number of features that are being captured. So whereas you can get an idea about thousands of RNA molecules, only tens or hundreds of protein molecules can be captured at the same time. There are computational challenges in proteomic analysis. There is issues that have to be proposed, and also standardization. All these issues need to be sorted out before moving this into a clinical laboratory. Now, there are, as mentioned by Dr. Basim, the issue of a single cell analysis in AFL. And there have been papers have been describing the utility of a single cell analysis. One of the major points in that is to expose or to study in much detail the blast heterogeneity. We all know these interesting cases that we see that being classified as acute leukemia or various lineage that include mixed phenotype leukemia and the ATP, the male ATP, the growth of male ATP, and so on. Single cell analysis is able to give you a more detailed look at the heterogeneity of these populations. Another important advantage of looking at the single cell is to study the blast plasticity and potential for gene switch. That has been really has practical implications in cases such as the KMT2A rearrangement, infant leukemia, especially in the younger age. With single cell analysis, you can actually look for a specific cells within the blast population that expresses a pattern that will make them resistant to therapy, such as steroid expression genes and potential for relapse. Also, with single cell analysis, you are able to look at immune evasion of the blast and study the blast microenvironment. And then the final category of advances in the lab has been the regulation of artificial intelligence, not only in the lab but in every aspects of the life. And that is based on the concept of machine learning with the two flavors with supervised and unsupervised. So this is all about generating data. Now, how about integrating and communicating? So classification by integration has been the tradition in the classification of leukemia. Dr. Adam has mentioned in the morning the FAB classification. He showed us images of different still the remnants of the FAB classification are still existent in the classification system right now, and the AML of otherwise specifies because of its intuitive issue based on the lineage and the stage of differentiation. Followed by the real classification, and now we are faced with a situation where we have two versions of classifications, the WHO 5 and ICC, the International Consensus Classification. And that, you can describe it as a schism right now in a classification of leukemia, which protocol we use, how to report it. Some people describe it as a setback rather than advance. Some people think about it as an opportunity to see two competing versions. My view of this one is just a reflection of the state of our knowledge right now. There's so much information about the genotyping, lots of sequencing data, some of that might pan out to be clinically significant, but we are sort of in a transitional stage of the knowledge. Hopefully, they will converge into one, back to one, rather than split into further subsets within each of the. The final thing that I talk about the clinical lab here is that we work in the clinical lab in a tightly related setting, meaning that not everything that appears in basic science or the translational research can be directly implemented into the clinical lab. We are working in the jurisdiction that you are working in. There are tightly regulatory and licensing issues that you have to deal with. There is a standard of care. There are financial constraints that the clinical lab has to deal with. And there is also the issue of proficiency. So it's nice to be able to do something, but when people come and ask me, yes, you have to be really careful not to be pushed by your clinical team when they want to introduce a new test or your internal desire having a test done in your institution. Some of these tests have significant implications on what kind of follow-up therapy that costly, potentially life-saving issues. MRD is an issue, so that should be efficient before we implement any test. So I then finally, I'm not going to take you through the diagnostic journey that we have at the hospital for sick children in terms of diagnosis. So usually within the first few hours of seeing the patient, we are able to log at the morphology and the peripheral blood, determine the blast, and we run flow screen, usually for the peripheral blood, are able to establish the lineage. And that will set the motion for the clinical team to move the patient from the emergency department to the inpatient unit. And that usually takes no more than 2 hours. And we liberally use flow cytometry. I describe flow cytometry as my extended microscope because there are so many challenges in identifying the blast morphology of a lab is typically emphasizing the peripheral blood or the nodes in the bone marrow, and the technologists in the lab, they know that their task not to miss a blast in the first gate that we see the peripheral blood description of 20% of they don't have circulating glass. Yes, no detected by morphology, but if you look really carefully, you can find them, and we usually run flow cytometry if we have any suspicion whatsoever in having glass. Diagnosing AML could be very easy, but that's no challenge when you have, 10 or more than 10% circulated glass. But the challenge is we could have an obvious blast child that is presented with bad cytopenia. Sometimes they are presented with just normal counts. So this is what happens in the first few hours, and then usually the first day or the second day, then we move into the morphology, detailed immunophenotypic analysis, and this is where we look into the heterogeneity, the potential of impact, and so on. And then we implement the rapid molecular testing. We still use the RT-PCR for PCR-able alpha. We use the FISH as well for the gene variation. And within 2 weeks, we get the full time. And the test that we are using right now at sick kids is an RNA-based NGS two-side cancer panel. Although we have developed RNA-seq as a diagnostic test because of the licensing and regulatory requirements, so we don't get an approval license to run the test as a clinical test as of yet. And then after the end of production, at 4 weeks, we have the flow cytometry-based MRT, and we are faithfully following the Children's Oncology protocol, which is clinically validated in the clinical trial, but we know that this is limited, so we have developed a 10-color MRT that complement the Children's Oncology group with the Euroflow markers. So we have okay, so despite all the efforts that we do in the clinical lab in trying to generate and communicate the relevant information to the clinical team to help them what obstacles to prevent the blast from achieving their goals. There are still blasts that continue to achieve their goals, and they overcome all the chemotherapy, directed therapy, the transplant, and CAR-T, and we still have lots of work to do to be able to isolate these bad actors. Hopefully in the future, the single cell multi-omics will be able to target the present diagnostics will be focused more on these bad actors rather than just getting. Thank you very much.
Thank you, Dr. Mohammed. Thank you, Faisal. I think maybe you have 10 minutes to give questions and answers to the two speakers. So, when I may start with Mohammed now, we heard Faisal talking about different methods used for MRE, the flow cytometry, the NGS methods, and when you combine them, the results seems to be much better than if you have one single. On practice, how do you see that in Canada? We hear from Faisal.
Yeah, so our practice, we are a children oncology group institution, so our strategy for doing MRD is, as Victor said, we use the same protocol as I mentioned, is used by the children oncology group, which is flow-based. We supplement that with the markers that are missing from that, but available in the for
this for the person. We don't do any particular GS, but we have for the person. For T and AML, so we are the biggest center in Canada, but I still feel that we don't have enough volume to be proficient in doing TA. So our strategy is to send out these cases to Brentwood Lab, children's hospitals, and just to do the TA, MRP, and then recognized reference code lab. However, we have been running our sort of local workflow TA language is actually pretty good. We compare our data with Brentwood, and there have been at least a couple of examples where we use fresh samples and there's transportation issues. So we compare our data, but I report their results. For the AML, MRD, I know that adults now they are moving more into NGS regular testing, but we are using again the COD reference lab, which is hematologics, was as mentioned the patient when they actually discover the discrepancy between pathology and MRD. So, but again, we send it out to them, we report them, but we have our workflow AML panel. Other than the 7 tubes that we have developed a 12-color tube that we use in addition to the 3 tubes. So we have our local panel, and again, we run it in parallel. We compare. Sometimes the sample gets lost or whatever, so we will report if the sample, there are issues with reference. And there are sample differences, but we have a backup in doing stuff locally, but we rely on the reference lab for both the T and AML. We have obtained co-accreditation when we decentralized 7 years back, and again, that is a suggestion to any lab that is thinking about doing MRD. You have to have an extended proficiency in program to be able to make sure that you are. This is a dangerous business because there is overlap between the hematologists and the MRD, and if you rely on the code only, it's good, but there are cases that could be missed. So you have to have the sufficient number, you have to have the infrastructure, the trained technologists, and the expert hematologists to be able to do this.
Thank you. Marcel, your experience with the use of flow cytometry NGS?
I think here in the Kingdom, flow MRDs used for B-cell AML, validated for T-cell in a number of centers, limited number of centers. However, for AML, we still rely on morphology. The challenge that we have here locally is that we don't have a central lab that we can send to say that, okay, we can rely on these testing. So unfortunately, our main method remains flow for B-cell AML or AML and morphology for AML. With limited exceptions, if we have a gene that is positive and we do have a PCR probe that is able to monitor that particular clone. So that's only for AML and AML. Obviously for CML, it's different.
Just maybe I can add for AML, King Faisal Riyadh is working on, with the adults are established protocol for MRD for AML. There is data will be presented later by Dr. Haytham Boubil this year, hopefully, inshallah. Any more questions before we conclude? Yeah.
the last please. Thank you so much. That was an excellent talk, and it's a huge moment in education. My question is about what's the future plan in Faisal Special Hospital? Are we going to move to artificial intelligence or what? Because you're really intelligence. You are a different hospital.
Now that's definitely one of the things that one of the goals of the hospital is to move to digital pathology and artificial intelligence at all levels. Now with digital pathology we started the program. It's hopefully we'll see it live this year or maybe next year. But for the integration of artificial intelligence, I think it will take some time to integrate the genetics, the morphology, and the flow cytometry to come up with an integrated report that would hopefully direct the therapy and monitor the patients in the future. I think with this one, I would like to thank the speakers for their excellent talks. Thank all the audience staying, and I think we will conclude this session unless there is any announcement. So the big photo. So please, everybody come.
وين نصلي بقى؟ في راسه الله يخلص القبلتين الفلوس اسال الشباب ممكن عندهم.
Yes. This one? Bismillah. Test mic. Check 1, 2, 3. Bismillah. Test mic. Check 1, 2, 3. Check 1, 2, 3. Bismillah. Test mic. Test. Check 1, 2, 3. Bismillah. 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 Test mic. Check 1, 2, 3. Bismillah. Test mic.
يا أنا
close. This is artificial.
هنا كده وقت جوه هنا بره انا ما هو بجيب له 30 دقيقه مكعب الكيس
কিন্তু উনি হিংসাও নাই মিয়া কিন্তু মায়া দেয় নাই মিয়া কাজ করবো কি তখন কত মায়া দিই কত কত বসে রাখতে
Check 1 2 Bismillahirrahmanirrahim. This mic. Check 1 2 this mic. Bismillahirrahmanirrahim. Okay. صوتك واضح.
سموها اسمع اعمل الكاميرا بالعرض ممكن اعملها لا بدك تفعل الروتيشن فعل الروتيشن عندك على ايوه حاول تكتب مكان بس حاول تتكلم شوي ترجع للمخ تستوى 3 تستوى 3 السلام عليكم زي الفل ممتاز فقط لا اسم لغوتك على او بي او دي اوكي
for the satellite symposium. It's sponsored by Orange. We have a speaker that you have seen this morning, Dr. Andrew Davis. I don't need to present him, neither in the morning nor now. He's well known in the common field, given this morning. So we know for a fact that since the publication of Passion in New England Journal of Medicine, rather more than 20 years ago, comparing the top with other articles, then only 2 times we were able to add on top, and both were done by Roche, rituximab and currently olatuzumab. So we'll hear from Andrew how olatuzumab has changed the way we treat diffuse large B-cell lymphoma.
Such a warm welcome. I hope you can hear me okay. I hope the people a long way away over there can see me okay as well. It's really great to be here, and I'm delighted to be able to present this symposium. I don't know if the AV guys got my slides ready, please. I'm going to talk about the use of patronage in the first line setting in combination with R-chip chemotherapy in patients with large cell lymphoma. And I'm going to present to you some of the data that updates our experience from the Malarix study. So just let me start off. This is an educational meeting, and of course we'll be happy to provide additional information should you require that. I have a number of conflicts of interest that I just want to be sort of explicit with as we begin this presentation. So, polatuzumab, you'll be very familiar with, is an antibody drug conjugate targeting a component of the B-cell receptor, CD79B. The antibody carries with it a cytotoxic payload, which is monomethyl-auristatin. And I think you're familiar with antibody drug conjugates that carry that cytotoxic payload through the use of brentuximab vedotin in Hodgkin's lymphoma and also in anaplastic large cell lymphoma. The cytotoxic payload is linked to the antibody by a cathepsin B sensitive linker. So when the antibody drug conjugate binds to CD79B on the surface of B-cell lymphoma, it's internalized. And in the environment of the lysosome, there is cleavage of the cathepsin B sensitive linker, resulting in release of free MME, which causes microtubular destruction and apoptotic catastrophe. Now, we've gained experience into the use of monomethyl-auristatin ADCs, and we've gained insight into the use of polatuzumab vedotin in patients with relapsed and refractory diffuse large B-cell lymphoma. As a single agent, we recognize that it has good response rates. However, it significantly enhances the effect of chemotherapy. And we know in the relapsed and refractory setting, if we add it to bendamustine and rituximab, we find that a doubling of the complete remission rate. And we find also progression-free survival and overall survival in the relapse setting is expanded by 3 times. So it was not altogether unsurprising that we should look to be using polatuzumab vedotin in the first line setting. And the Malarix trial will be familiar to you. This recruited previously untreated patients with diffuse large B-cell lymphoma, aged between 18 and 80, with an international prognostic index of 2 to 5. Almost 900 patients were recruited into the study, and they were randomized to either receive conventional R-CHOP chemotherapy or polatuzumab in addition to R-CHIP chemotherapy, the Christine being removed because of the presence of the microtubular inhibitor in polatuzumab. And it was a double-blind study, and the primary endpoint was progression-free survival. And we recognized that almost 900 patients recruited, about 2/3 of these had an IPI score of 3 to 5. The majority of them had diffuse large B-cell lymphoma, NOS. Now, the primary endpoint of the study was reported at 2 years by Italy in the New England Journal of Medicine in 2022. This demonstrated a positive outcome. Progression-free survival was significantly improved with the addition of obinutuzumab, the hazard ratio of 0.73. And what that meant was an absolute improvement in progression-free survival of 6.5% at 2 years. So this was a positive study, and despite having had so many different studies conducted in diffuse large B-cell lymphoma over the last 15 or so years, this was the first one to really change the dial and to present a new standard of care as frontline therapy. I don't know if any of you guys can, I don't know if you noticed there is a big echo at the moment. I don't know who's running the sound. Thank you. So as a result of this positive trial, many territories have approved the use of obinutuzumab in the first-line setting in combination with R-CHP chemotherapy. In the UK, our National Institute of Health and Care Excellence has given approval to the use of this, and it's been pretty much universally adopted in the UK and very many other territories. We don't use obinutuzumab in the non-Lawrence patient population. So patients over the age of 80 we don't give obinutuzumab to, and we do not give that to patients who have an IPI score of 0 to 1. Because remember, the study population was an IPI score of 2 to 5. Now, at ASH this year, the 5-year follow-up of the Lawrence study was presented. And I think this presents new and important data for us to consider as we make our choice of first-line therapy for patients with diffuse large B-cell lymphoma. The first point was that the difference in progression-free survival was maintained at 5 years. We can see that hazard ratio was continued at 0.77. That which has been really important is the economic models to see that that difference in progression-free survival remains parallel and continues with 5 years of follow-up. So we see an ongoing improvement in PFS in patients who receive polar R-CHP over those patients who receive R-CHOP chemotherapy. What's really important is the difference in the need for subsequent therapy between those patients treated with polar R-CHP and those patients treated with R-CHOP. And in fact, there was a 23% reduction in the requirement for second and subsequent lines of therapy in those patients who receive polar R-CHP. And when we look at those differences, we can see the number of subsequent therapies are shown for R-CHOP in the blue, and polar R-CHP that can be seen in the green. And you can see for all of these different therapies, whether it be chemotherapy, radiotherapy, high-dose chemotherapy, stem cell transplantation, or CAR T-cell therapy, that there is a requirement for fewer therapies in those patients who receive polar R-CHP. And that's important not from just an economic standpoint, but it's also very important from a patient experience point of view. Having treatment for relapsed and refractory large cell lymphoma has a toll in terms of toxicity, and it has psychosocial consequences, particularly some of the more intensive therapies. So reducing subsequent therapies really is important for our patients and our patient experience as well as economics. Now, at 2 years follow-up, no difference in overall survival was reported. Now, with 5 years of follow-up, what we can see is that the hazard ratio has moved further away from 1. And with 5 years of follow-up, the hazard ratio in favour of polar R-CHP in terms of overall survival is 0.85, having been 0.94 when the study was first presented. Now, this study was not designed to show a difference or how to show a difference in overall survival. And what we do recognise is the effectiveness of some of our subsequent lines of therapy. But I think we've all been encouraged to see that opening up of the overall survival curve, although it hasn't reached statistical significance yet. There are certainly numerically fewer deaths observed in the polar R-CHP arm compared with those patients treated with R-CHOP chemotherapy, giving us a hazard ratio of 0.85. Now, when we look at the numbers of deaths associated with progressive disease and those from other causes, we can see a clear difference. In the R-CHOP arm, there were 51 lymphoma-associated deaths, but just 40 in the polar R-CHOP arm, giving a clear difference between the different treatment arms. Now, we've had a lot of conversation about the subgroup analysis, and the subgroup analysis, we must remember, is purely hypothesis generating, and the size of any of these subgroups may be relatively small. But we can see with 5 years of follow-up, the confidence intervals or those subgroup effect sizes have got tighter, and we generally see across all of the subgroups clear benefits from the use of polar R-CHOP. There's been a lot of discussion about the benefits of polar R-CHOP in the ABC subgroup, not just from the LARIC study, but from another range of observational studies. What we see, the subgroup of the ABC group, is a significant improvement in both progression-free survival and a 16% improvement in overall survival in those patients with the ABC phenotype. But actually, all of those subgroups demonstrate benefit across the study. So I'm a great believer that we should be using pembrolizumab in the intention to treat population rather than selecting out underpowered subgroups. Now, the LARIC study has been extended in terms of the sample size, and when recruitment was completed, an additional 121 patients were recruited from China to get some extra data and an extension cohort to really help bring up the number to 1,000 patients in the study. When the overall survival of the whole population, including this expanded Chinese study group, is included, we see that the hazard ratio for overall survival is 0.83, and we start to see a greater divergence in those overall survival rates. When we look at the causes of death in the whole global patient population, we can see a difference in lymphoma-related deaths. Now, the bottom two curves are the deaths from non-lymphoma-related causes. And you can see in the blue, which represents R-CHOP, and the green, which represents polar R-CHIP, that the difference in non-lymphoma deaths is probably very similar. We don't see any great differences with 5 years of follow-up. But when we look at the lymphoma-related deaths, we can see that the blue and the green curves start to diverge at the top here after about 36 months. And that's because we're seeing a greater number of lymphoma-related deaths in the R-CHOP treated patients compared to the polar R-CHIP treated patients. I think that's important for us to look at. When we look at overall safety, there's no new safety signal with 5 years of follow-up. However, interestingly, we see a clear difference in the number of patients with second malignancies in the patients treated with R-CHOP compared with the patients treated with polar R-CHIP. So if we look at all grade second malignancies, there were 12 reported cases in the R-CHOP treated patients, but only 5 in the polar R-CHIP treated patients. Now that number is small, but I think it really plays theoretically to the fact that those patients with R-CHOP, because there are a greater number of progressions, had greater exposure to second and subsequent therapies, which may come with an increased risk of carcinogenicity. So, in summary, the 5-year extended follow-up of LARIC shows a sustained and significant improvement in progression-free survival of polar R-CHIP over R-CHOP chemotherapy. There's a requirement for fewer subsequent anti-lymphoma lines of therapy with polar R-CHIP and numerically fewer deaths. There's general consistency in the effect size across all of these exploratory subgroups, and we've had lots of discussion about this over the last 2 years, and the safety profile has really remained similar. And so certainly polar R-CHIP should be considered the standard of care for patients with previously untreated large cell lymphoma. Now, as a result of the interest in this data and the divergence of those curves, then a 7-year follow-up of LARIC is now being planned. Now, I'm just going to delve a little bit more into the biology. We've seen presented at ASH in 2023 this difference in outcome according to the cell of origin. I think what's really important to remember is when we see this difference between ABCs and This is based entirely on transcriptional profiling rather than the immunohistochemical surrogate that we use in our everyday clinical practice. And we know that immunohistochemical surrogates often miscause whether a patient is ABC or GCP. We also know that within GC lymphomas, there's a group of highly proliferative dark zone lymphomas which carry a range of different oncogenic aberrations which seems to particularly benefit from the use of polar R-chip. So if you are not giving polar R-chip to patients with GC lymphomas, then there's this group of patients that you're denying a therapy which has really significant and important benefit. So let me just tell you about a couple of patients that I've treated recently, just by way of raising some points of discussion. This is a 56-year-old lady who presented with an 8-week history of abdominal and lumbar back pain. She's otherwise fit and well, no significant transmitted history, and clearly on examination she's got a large abdominal mass, she's got a suprapubic across the lymph node on the left-hand side, and lower limb edema. She goes into the CT scanner through the emergency department, has no disease apart from the diaphragm with the placement of her inferior clinical leader. And we do a biopsy which is diffuse large B-cell lymphoma of a GC phenotype. When we get the cytogenetics back, she has a translocation involving medium BCL2, but not a classical double hit, but actually the two are translocated as partners. This is a so-called pseudo double hit, of which we really can't understand the prognostic significance of that. There's some data suggest it may be associated with that prognosis. Her LDH is over 3 times the upper limit of normal, and her PET scan shows what we can see here, no extra over the side, but extensive disease both above and below the diaphragm. So she is a stage 3A large cell lymphoma with an IBI score of 2 out of 5. I treated her with polar R-chip, and we can see the results of this, that by the interim PET scan after 2 cycles, she was in a complete metabolic response. And so we were able to go on and to deliver 6 full cycles of polar R-chip, which was very well tolerated. She had great non-peripheral neuropathy, which we would expect to see in patients treated with R-CHOP chemotherapy. We were able to deliver 100% dose intensity, and she had had only 1 admission with an influenza A clear with that with hospitality. And we consolidated her first remission with radiotherapy to the site of initial bulk. This is a great area of contentions and practice that we continue to use even in the PET era. Some of my colleagues and so very many other territories have banned this, but this is our approach to bulk. And so by the end of her, we had her reduction treatment, she was in a maintained remission. So this is really demonstration of using polar R-chip in a patient with GC phenotype and a patient who was in a complete metabolic response. The second example is of a 67-year-old man who presents once again to the accident emergency department with progressive abdominal pain, this time with night sweats and some weight loss, but didn't reach the 10% criteria, with some decline in his performance status. He'd been a non-insulin dependent diabetic for the last 10 years and had recently, well over the last 5 years, had less control of oral hypoglycemics and had started on insulin treatment, was receiving a 5-phase insulin. He was hypertensive and he was overweight with a BMI of 44. The CT demonstrated parathoracity abnormality in mesenteric abnormality. His spleen was 16 centimeters and there were mesenteric islands. He had an LDH of over 2,000, he had a mild normal growth cystic anemia, and he had some renal dysfunction with a creatinine of 158. A CT-guided biopsy of the mesenteric lymph node showed diffuse large B-cell lymphoma of a non-GC phenotype. We do not have access outside of clinical trials to transcriptional profiling, so I don't call it ABC or GCB. There was a high proliferative fraction, there was mixed immunohistochemical positivity and BCL2 immunohistochemical positivity, but no evidence of a translocation, just extra copies of the MYC on the FISH analysis, so this was a double expressor phenotype. There was some reduction in his left ventricular ejection fraction to 50%. The cardiologist felt it was okay to give him full course anthracycline, and we did we added in some cardiac meds at the time, cardiac optimization. So, here's a stage 3B with an IPI score of 3 out of 5. That's a double expressor. The criteria for the IPI is based on age, stage, and the raised LDH. He had polar R-chip. He achieved a complete metabolic response by the second cycle polar R-chip, interim PET scan that was negative. We were able to go on to give him 6 full cycles of polar R-chip, and after 6 cycles, he is also doing a complete metabolic response. Now, I was very certain with this man, who brings a burden of comorbidities, that I really wanted to try and avoid him having second and subsequent lines of therapy. Because of course I know that the intensive therapies, given his burden of comorbidity, he would tolerate less well. There are also a number of factors about his lymphoma, including the phenotype, which really encouraged me in the IPI to want to use polar R-chip in this patient. So I go back to the fact that by using polar R-chip, you can reduce the requirement for second and subsequent lines of therapy. In fact, there is an estimate that if there's a global adoption of polar R-chip, then 27,000, almost 28,000 patients globally will require less therapies in a decade than we would have done if we continued to use R-chop chemotherapy. So I think that's a really important statistic. I'll give you some very brief real-world experience from my colleagues who have looked at a comparison of an era of polar R-chip, which is our current adopted standard of care in the UK, and R-chop chemotherapy. We can essentially say that in the real-world setting, polar R-chip is behaving exactly as we would have expected from the pivotal Polaris study. We see high overall response rates and complete response rates, and although this is not significant, the numerical number of CRs is much greater. We see a similar rate of infectious episodes, but we recognize that patients appear to be spending less time in hospital if they're treated with polar R-chip chemotherapy. I have no doubt at the summer conferences we're going to be seeing bigger series of the application of polar R-chip in the real-world population. So in summary, Polaris, now with 5 years of follow-up, shows a maintained benefit in terms of progression-free survival. We see that the overall survival hazard ratio is moving apart and moving away from 1.0. We're seeing a reduction in the need for subsequent therapies. We're seeing differences in cause-specific survival, favoring polar R-chip. We can see this benefit in the ABC subgroup. We see lower second malignancies in those patients treated with polar R-chip, and this will be subjected to a further 7 years of follow-up. So in summary, pembrolizumab is no doubt an important addition to our therapeutic armamentarium. We recognize that the cost-effective benefit, that's why it's been adopted by the NICE in the UK, and it clearly reduces patient exposure to toxic and socio-economic challenges of second and subsequent lines of therapy. Thank you very much for listening. We're very happy to take any questions.
Thank you, Dr. Andrew. Elegant presentation as usual. I guess we've started a little bit late. We can have just one question, if there is any. I have a question. I mean, patients upon relapse, recommendations within 1 year CAR-T, post 1 year chemo, photo. But there are patients that cannot go for either or. And patients, when they go for CAR-T, they need some form of bridging. One of the commonest bridging regimens that we use currently is pola-BR. Now, after patients having been treated with pola-based regimen, would you still consider that in the second line setting?
So I think that's a really good question. So when we started off on our CAR-T center in the UK, we were in a similar situation. We used a lot of pola-BR bridging for our patients post-apheresis. Now, patients obviously are increasingly exposed to pola-BR in the first line setting. I think we have to be careful about extending the number of exposures to pola beyond the 6 that you might get with polar R-chip chemotherapy. Now, I see the majority of patients that I give CAR-T cells to in the second line setting are chemotherapy refractory. Either they're absolutely refractory or they're relapsed very early on completion of chemotherapy. So So I don't believe chemotherapy-based regimens are very good at bridging. And actually, our approach to bridging in the UK now is almost primarily radiotherapy. We use a lot of radiotherapy as bridging because it introduces a new therapeutic modality. We still use a little bit of a platinum-based regimen, but I think we've been able to successfully get a high number of patients in the second-line setting of CAR T-cell therapy without the need for radiotherapy.
All right, thank you very much. With this, we conclude the satellite symposium by Osh, and we go to the next session. Thank you very much.
Thank you, Brian. Thanks, everyone. Good afternoon again. I will invite my colleague, Dr. Liju, to introduce the second session and the moderator and speaker.
Thank you, Dr. Ziad. After the great session, we honored to have a really good speaker in the next session. It's on advanced clinical trials for precision oncology. So if I may invite Dr. Kaplan, Chair, to the stage, Professor Abdul Khairi, also to the stage as the moderator. So the first talk will be on platform trials and efficient design for evaluating multiple treatments. So let's hear from first, Dr. Kaplan will introduce the speaker and David, please come on the stage.
Thank you, Dr. Liju. The first speaker is Dr. David Morgan. Dr. David Morgan gained degrees in mathematics and applied statistics from Oxford University. He has a 30-year career in the pharmaceutical industry, laterally with Biopharm. He was president of the European Federation of Statisticians in the pharmaceutical industry from 2001 to 2003. Thank you, Dr. Morgan, for joining us today.
Sometimes people get alarmed at what statisticians might say to them. A long career working in clinical trials means that hopefully we're pretty pragmatic. But of course, what we end up with in all clinical trials is data. And data needs to be managed. And statistical science is the way in which we do it. So what I'm talking about is platform trials. I'll explain what a platform trial is. I'll take you through that most easily shown by practical examples, one in early stage breast cancer, one in advanced prostate cancer, one in COVID, though we probably will skip over that one. What are the advantages and disadvantages of them? So platform trials really come as they're a type of master protocol. And there are three particular types of master protocol that we have. In essence, master protocols provide us a way of doing many trials in one. So we're trying to take the advantages of what we would normally need to do multiple trials all into one. So a basket trial will test one intervention, and I'm thinking particularly about drugs, in multiple diseases. So an example from my history is somebody had a drug in Rosostat. We knew it would be, or we knew it was likely to be active in hormonal cancers. So we did a basket trial, so we tested the trial in breast, prostate, endometrial, and ovarian cancers simultaneously. And that's given you the advantage of an early stage trial. Vemurafenib was tested in a similar style in 8 tumor types. Really, all cancers apart from melanoma. Most of these basket trials are phase 1, 2, and they're mostly sponsored by industry because you're talking about one drug where the company holds the intellectual property and investigating that in different diseases. The reverse way around, we have umbrella trials where you're testing multiple interventions in a single disease. Again, mostly phase 1 and 2, mostly public sector sponsored because you're talking about products or potential products from different companies. And then platform trials are long-term or even perpetual umbrella trials which have products entering and leaving the trial over time, but critically according to pre-specified criteria. So the key point of platform trials is you investigate different investigative drugs using a common control. And the definition from US FDA people to study multiple targeted therapies in the context of a single disease in a perpetual manner, with therapies allowed to enter or leave the platform on the basis of a decision algorithm. And you can then evaluate multiple treatments, and you don't need to set up separate protocols to do it. You've got more work in planning at the beginning to set it up, but then you can introduce new products, you can take things out without the complexity of planning and setting up a new protocol or recruiting and qualifying new centres. And I quote this from the Stampede trial, they answered at least 8 different primary questions in 15 years. And in the context of prostate cancer, that is really extremely difficult. So putting it into pictures, a picture's worth 1,000 words, we've got the trial here starting with the standard of care and 2 interventions. Randomised between those, and then at the first interim analysis, we've got one arm dropped. Intervention arm 1 has been found not to be effective, that is futile, that is dropped, and a new intervention, intervention 3, is brought in. At the second interim analysis, nothing drops out, but there's another intervention brought in. So you continue working through time, providing a platform, hence the name, for different interventions, different drugs to be brought in. And the process within a trial, enroll patients as ever, randomise them, record the outcome, update the trial data, update your statistical model, then evaluate the determination rule. And that can have 3 outcomes, really only 2 here. One is to continue, the other one is to stop. And you can stop either for futility, this drug clearly isn't working, or for you've demonstrated that it has potential efficacy and graduated to move it into phase 3. So let's look at the I-SPY trial. This is neoadjuvant therapy for early stage breast cancer. It began enrolling in 2011. They planned almost 2,000 patients at 16 centres in Canada and the USA, and chief in the USA. It was an open-label phase 2 trial, and they defined 10 subsets of patients, which they called drug signatures, but they're biomarkers basically relating to HER2 status and other estrogen receptors. And the process to include patients then was to assess the biomarker status and other eligibility criteria, then randomise them to one of the available interventions. The goal of the study being to identify combinations of experimental drug with standard chemotherapy, and the standard chemotherapy defined as the control. Primary outcome was defined as pathological complete response. If you're going to do this sort of trial, you need to get fairly quick answers. So they're using a surrogate measure that had been measured at 36 weeks, which then decided what happened next. Patients were followed up subsequently, and so the secondary outcomes were relapse-free survival at 3 and 5 years, overall survival, and tumour volume also. What you could do is randomise patients equally between the treatments at each point, but this one is an adaptive trial, and Green's going to talk a bit more about adaptive trials. And so they actually changed their allocation probabilities in the randomisation over time, which has the advantage of more patients receiving the more successful interventions. The sample size wasn't predetermined. Each treatment arm continued until they got a signal of success, meaning strong chance of success in a reasonable size phase 3 trial, or futility, meaning you've got a very low predictive probability of success. And so what they did, they started recruiting patients in 2011. By 2019, they had graduated 5 successful drug combinations through to the phase 3 trial, which they called Great Imagination I-SPY 3. At any one time, they had up to 5 study arms plus the control. By 2024, the latest update they published, they've had 40 experimental interventions entered, 15 papers have been published in top journals. Funding is an issue. Again, you won't find funding in the public sector, or in the private sector for that matter, for trials that might take 15 years. So it was originally funded by the National Institutes of Health. Now it's a pay-to-play model. So pharmaceutical companies apply to have their compounds evaluated in the trial and pay. They provide the drug and pay more money. And this study is still recruiting patients in 2024. And there's the really showing in diagrammatic form the products coming in and out. The dark blue are the products that graduated into phase 3. The red colour are ones that were halted for futility. Green means they are continuing. In other cases, they found different rules to complete. Our second example is Stampede. This was a UK trial done in advanced or metastatic prostate cancer, run by the UK Medical Research Council. They always refer to it as a multi-arm, multi-stage trial. Platforms, the American research, MAMS, tending to be the British and European. They are the same thing. This trial recruits men with locally advanced or metastatic prostate cancer who are starting long-term hormone therapy and then looking at what you can compare to that right onto it. They set up 110 centres in the UK, plus 10 in Switzerland. Started in 2005. Initially had 5 research and 1 control arm. The control arm being ADT alone. I perhaps should say the control arm was triptorelin, decapeptyl from Ipsen, the company I work for. Perhaps also I should say that my daughter was the study statistician on this for the first 5 years of the trial. So by the first analysis, you've done 5 years. The first analysis, 1,400 patients have been randomized. It had 129 failure events, progressions. What do they mean by multi-stage? And again, they're looking at it in one sense. You've got phase 1, phase 2, and phase 3 combined here. You've got a pilot stage looking just at safety and feasibility. 3 intermediate activity stages, where they're looking at failure-free survival, all clearly defined in the protocol. And then the final stage, the efficacy stage, long-term follow-up for overall survival, and all done within the same protocol. They did an interim analysis after the second activity stage, the first one in March 2011, that's 6 years into the protocol. At that point, they dropped 2 research arms. Activity stage 3 therefore continued with control of 3 research arms. The advantage they got was no more regulatory or ethical approvals required, as it's all planned in the protocol. And then they added a new research arm, newly licensed in 2011, you may have heard of Al-Madinah. Perfectly timed, get a big assessment of that going on as soon as it was licensed. By 2019, they were up to protocol version 17, which was actually the final one, I think. The study had adapted, the control treatment, standard of treatment had changed, partly because of the results of this trial, to add a standard regular therapy that does Taxol onto the hormone therapy. And then they had Arm K, looking at adding metformin to the standard of care for non-diabetic men. So you've got a sort of sub-study of a particular subgroup. And another arm looking at now as an alternative to the ADT, of looking at transdermal estradiol as another way of providing treatment. And it also enabled numerous sub-studies to be added in among the recruited patients, looking, for example, at some centres looking at genetic genetic markers, some centres looking at quality of life. So really this overarching study enables a lot of different research to be done. And so just following that through, recruitment completed in March 2023 with nearly 12,000 participants. Final results are expected this year. What are the advantages of the platform trial? One is speed of operation once you've got it started. There's no new regulatory or ethical approvals needed between stages. Trial sites are identified and trained. You get parallel answers to important questions. Quotes for Stampede, we will have answered at least 8 different primary questions in 15 years. To have addressed that in separate sequential trials would have taken many decades and far more patience. The fact it's not run by industry, it's run by a public body, will give higher credibility in some quarters. Those of us coming from the industry moving into the academic world are always surprised by the absence of formal quality systems. But these are well-run studies. But one disadvantage is you may well need multiple countries to achieve patient numbers, and that can be difficult to arrange with public bodies, which are funded very often by the government of one country. It also helps with the inclusion of patients with rare diseases, with the idea of developing an expectation that all patients available will go into a clinical trial, and that can really help with progress on rare diseases. Can give a complication. There's a study set up by the Medical Research Council in the UK in multiple sclerosis, which is not that rare a disease. They've been so successful in getting a waiting list for people to get onto the trial and have patient expectations in that. But in rare diseases, it can be a really good way to maximum amount of patient data. But what are the difficulties? Well, planning it up front is complex and time-consuming. From a scientific perspective, really, you're trying to plan for all possible combinations of outcomes. You're trying to anticipate the trial environment over the next 10 plus years. The long duration may require update to the standard of care, perhaps from the early results published, and indeed, we saw in Stampede that can be handled. The key point scientifically is that you need to ensure meaningful comparisons between the treatments. Classically, you can only compare between groups that are randomized at the same time. Can I compare treatment X now with results I got from standard of care patients in 2017? All sorts of reasons why that might not be a fair comparison. But there are model-based adjustments. In iSpy, they talk about their Bayesian time machine, which sounds a bit like science fiction, but it's a model of how things may have happened over time. You're also doing lots of different comparisons, and we'll see that can be a problem. Again, the more comparisons you make, the more chance you've got of a false positive result, but that can be handled. But the difficulty you have is, in fact, that there are only 16 platforms started by 2019, mostly in oncology. But then there were 28 registered in 2020, of which 21 were in COVID. I'm not going to take you through that, other than to point out that the recovery trial done in the UK built on work that had been done previously, trying to set up a trial for MERS coronavirus with Saudi colleagues. I don't know who those colleagues were working with the Oxford group. But having things prepared for some outbreak breaks is critical. So let's go across that. I've given the references at the end. And thank you for listening.
I think we'll continue with the talk. We'll invite Professor Andy, please. He's a professor at King's College London. He's a founder member and former chair of the statisticians in the pharmaceutical industry, and is past president of Royal Statistical Society. He has 50 years of experience in the pharmaceutical industry, including SIBA, DG, Seneca, Faisal, and UCB. It's a great honor to have you, Prof. Andy. So please.
The earliest phase of human exploration of dosing in humans. So what I'm going to do is give you some background to the problem that we're trying to solve. And I'm going to give you examples of 3 generations of solutions to the problem. So-called 3+3 design, which has been around for a very long time. Model-based designs, which started being used in the early 1990s. And lastly, model-assisted designs. So what is the problem? Well, we are trying to come up with the notion of some estimate of what's called the maximum tolerable dose. And in order to do that, we take a number of doses that you compound, and we're looking to find out the acceptable dose for treating future patients in future trials. And the assumptions that we have is we have some definition of what is dose-limiting toxicity. We know that most new treatments that we're going to be giving, there is going to be some toxicity. But at what level does it become a problem for the have a definition of what is dose-limiting. And we have a definition of a maximum tolerated dose. And normally, that definition would be what is the probability of experience of dose-limiting toxicity given the maximum tolerated dose. Is it 20%, 30%, is it 40%? Have that. Now, the problem that we have is that the sort of model that's lying behind our thinking is that the likelihood is that if you increase the dose, the probability of the response of the immunization is going to go up. But the problem is the probability of toxicity will also go up. And these conflicts because the first one is good, but the second one is bad. So we want to go as far as we can to get as much efficacy as we could with the light, but we don't want to go too far because we have a problem. But of course, as ever, there are practical constraints, and ethically, what we want to do is to select doses sequentially for small cohorts of patients. We don't want to expose too many patients too quickly to toxic. Very little, because this is the first in human, very little will be known a priori about the likely shape of those response curves. And of course, patients are often very heterogeneous. respect to the clinical team, it doesn't need a statistician, which, from my perspective, is bad. And it's generalizable. It doesn't have to be because really you have A plus B, where A and B equals not. The negatives are that the MTA is not far. In order to run it, you have to be a definition of what is far. It has to be shown that a high chance of keeping it in effect. And it doesn't utilize all the resources to make it We then build a model for that close response, and we're using what's called a Bayesian analysis, where we incorporate prior knowledge into the analysis. And we then get an estimate of the dose response curve in blue on the right, and we choose as the next dose that those whose estimated response is closest to our target. In this case, that's choose that as the next dose, runs, we run that through a cohort of patients, we update our model, and we choose the next dose closest to. So here's an example from the British Journal of Cancer in 2006. On the right-hand side, you can see there are 6 cohorts. You see the administered dose of each cohort. Decided to skip and that was contradicting the plan in which doses were not supposed to be. Both patients at that 25 milligram experienced it. Now, if you look at the model outcome for CRM, for that data, it was recommending either a dose of 30 or 40. Well, that was decided that was unsustainable because we already see at 25 milligrams that both patients suffered DLT. And to then potentially double the dose was not a good idea. But that's what the CRM, the model was recommending. And so what they did was they said, well, what are the things that we really want to know? How likely is it that the true DLT rate in that dose is an underdose? How likely is it that the true rate is in the target interval, whatever that is? And how likely is it that it's an overdose? Where overdose would be either excessive toxicity, greater than the target rate, or potentially totally unacceptable. And so they defined, if you like, the interval of 0 response to 100%. They defined 4 intervals. And the dose recommendation for the next dose is to select the dose that fulfills the following criteria. We choose the dose that maximizes the probability that the true rate is in the target interval. And then there's an overdose control, which says that there's less than a 25% probability that the DLT rate exceeds some target. And here's an example from 2013, clinical cancer research. Don't worry about the A graph, but the B graph are the numbers of patients who were treated at each dose, and the filled-in squares are if they suffered a DLT, and the open ones, no DLT. And you can see at the top, they put a lot of patients on an expansion cohort, and that allows us to examine what happens in a larger cohort of patients. In the bottom left-hand corner, you can see the probability of it being underdose, in the target, or overdose. And so the greens are good, the reds are bad, and the blues are also. So that's fine, and the CRM was a distinct change in emphasis in maximum tolerated dose studies. It introduced Bayesian ideas, and it's estimation rather than an algorithmic approach. But because it has only one parameter, it's actually not very flexible to model real data. And by concentrating on the target dose alone, it can be unsafe. And there are two alternatives. One is the one I showed you from Novartis, and the other is what's called the E-model approach, which is to do with overdose control. When you think about developing or evaluating such a design, what we look to are, is it safe? Does it perform well under different scenarios? Is it simple? And is it transparent? Now, it could be argued that the model-based approaches don't meet this because they're not necessarily transparent for clinical teams. I think I would dispute that, but I can understand that might be the case. So, more recently, there have been 2 or 3 or multiple proposals to come up with something that looks a bit like 3+3, but has a model underlying it, assisting you in making those decisions. One is the modified toxicity probability interval, and essentially it defines a partition in the same way as the Neutragen approach did, a partition of the interval into 3, and you choose to escalate, de-escalate, or stay at the same dose, depending upon the so-called unit probability mass of being in those 3 intervals. And that's defined as the probability of being in the interval divided by the width of the interval. And then there are safety rules which allow early termination and exclusion. And if you put in all the assumptions you made into a piece of software which is freely available, you come up with a decision table, grid. And essentially here on the horizontal, you have the number of patients treated at the current dose, and on the vertical, you have the number of toxicities at the current dose. And for each of those squares, you have a decision either to escalate, stay at the current dose, de-escalate, and the red ones are the current dose is unacceptably toxic, and so you have to de-escalate. There are others. There is a Boeing design, which I'm not going to talk about because I've run out of time, but I think my colleague Alan Phillips was going to mention it in his talk. And these newer designs are trying to have the benefit of a model-based approach at the same time as having a degree of simplicity for clinical teams to be able to implement. And so, in conclusion, the old-fashioned 3+3, I still think is probably the most used design in first-in-human studies. It may not be up at 95%, probably about 65 to 70% these days. I think that's a shame because I don't think it's the best approach. The model-based approaches, I think, are valuable and they should be used more often, but I accept that there is an element of black box in there, and the model-assisted approaches, which have been developed more recently, I think are a compromise between the simple 3+3 and the model-based approaches. The research in this area is not over. Many statisticians have built careers around proposing new designs, and I hold myself guilty of that too. Thank you very much for your attention.
Thank you, Dr. Reed. Now we'll move on to Professor Al Phillips. Professor Phillips has spent 40 years working in the pharmaceutical and CRO industry. He's worked both in Europe and in the US. He has experience in providing biostatistical input into clinical development plans and a wide range of therapeutic areas. He has experience in individual clinical trials, design and support preparation of biostatistical regulatory questions, and attending FDA and FEMA scientific advice meetings. He is a professor at Morehouse University and a senior lecturer at King's College London. He has also been editor-in-chief of the Journal of Pharmaceutical Statistics. Professor Phillips will talk to us about Project Optimus, an FDA initiative which is form dose optimization in oncology drug development.
Thank you. Thank you. I'd like to start by thanking the organisers who invited me to speak here. Like Professor Reed, this is the first time I'm really sounding impressed by speaking. I'm going to talk about Project Optimus. I'm going to start with a disclaimer. I do not work for the regulatory authorities, so this is Project Optimus as seen by the consultant. I'm going to talk about what I think are the rationales for it, the opportunities of drug development, and the challenges. A common or typical early phase oncology development program comprises two stages. As Professor Rees has already said, stage 1, phase 1, is about identifying the maximum tolerated dose, usually based on DLTs or dose-limiting toxicities, however those are defined. There's 3 types of study designs that are used. There's rule-based designs. Andy has already explained the 3+3. There's model-based designs, CRM, and there's now model-assisted designs such as the one which I'll come back to on the next slide. Once the maximum tolerated dose has been identified, then a cohort expansion is done with the maximum tolerated dose for proof of concept. And what they're doing there is usually a single arm using some kind of surrogate endpoint such as objective response rate to see whether or not the MTD gives some kind of indication of efficacy. And there's 2 common designs there that are frequently used. assigned as two-stage design and something called the POSS 2 design, which I won't go into. Today, within the last year, I did a survey and still over 70% of published papers use the 3+3 design. And that's known to not provide a reliable estimate of maximum tolerated dose. These model-assisted designs, one of them is called the Bayesian optimal interval design, or I call it the BOIN, belong to a family. There's a family of designs that can be used. And on the right-hand side of this diagram, you'll see several designs that can be used to identify the maximum tolerated dose. The BOIN is in the bottom, it's the green one. And as Professor Greaves has already said, it combines the simplicity of rule-based designs with the superior performance of model-based designs. It's simple, and dose selection of the next cohort includes a very simple comparison of DLT rates as per the 3+3. It gives far superior improvement in the estimation of MTD, and if you only take one thing away, stop using the 3+3, the rule-based, and use some of these more model-based type of designs. It's also recognised by the FDA under their Fit for Purpose initiative, so if you go to the FDA with that type of design, you don't get any questions. In the bottom table, I've given escalation boundaries and de-escalation boundaries for different target toxicity rates if you're interested. However, the oncology landscape is changing, and it's changing fast. For example, I recently worked on a specifically engineered molecule that was designed not to give any toxicities at all. But the development program is still based on the old cytotoxic chemotherapy. So is actually estimating the NPD appropriate and then using that in the phase 2 and phase 3 studies. Furthermore, there's been an increase in the number of post-marketing requirements and commitments on oncology approvals relating to dose in the product labels. And so there's been some examples recently, and I've listed them here, where the post-approval studies have led to changes in the label regarding dose. And this is really one of the main reasons behind the rationale of Project Optimus by the FDA in my opinion. It's an initiative to reform the dose optimization and dose selection paradigm in the oncology drug development world. Because the current paradigm for dose selection based on the MTD tends to lead to doses and schedules that are often inadequately characterized and lead to doses that provide more toxicity without additional efficacy, severe toxicities that require a high dose or rate of dose reduction, etc. So Project Optimus is designed to reframe the early phase oncology development program. What they're after, rather than taking a single dose, the maximum tolerated dose, and expanding that for phase 2, they want sponsors to evaluate dose S, multiple doses, for both safety and efficacy. They're looking for more PK/PD data. They're looking for better dose and exposure response. They're looking for better interpretation of toxicities after the period that is used to identify DLTs for the early phase in things like the 3+3 or the BOIN. And they're also looking for the impact of toxicity on quality of life, putting the patients first. So a potential future oncology development paradigm might look like something like this, and this is just my view, that in phase 1 there's going to be a lot more exposure and response modelling. There'll be a lot more dose response modelling using potentially biomarkers. We're going to have to use smarter early phase designs, none of these simple rule-based designs, maybe model-based. And what we're going to have to do is select multiple doses for study in phase 2. Phase 2 then, we will take those doses, which could be 3, 4, 5, and then do some kind of modelling using something called the OCP model to select the phase 3 dose. It could be, if we're really advantageous, to look at combining phase 2, phase 3 and an adaptive design but I'm not going to go into that today. An example of a smarter design is something called the Boeing 12. Now the Boeing is designed to identify the maximum tolerated dose. It's on the right-hand side. On the left-hand side, the designs have been listed that are designed to find the optimal biological dose. The Boeing 12, which I've listed, actually identifies it by using something called a utility measure to look at risk-benefit. And without going into too much detail, you can think of a utility function as a measure of the desirability of the dose. As an example, suppose that the toxicity-efficacy trade-off is binary. You can either have toxicity or efficacy, or you can't. So it's a yes-no. Then this table below shows that for any patient in the trial, there's really 4 outcomes. The most desirable is to have efficacy without toxicity. We all like that. And the worst is no efficacy, no toxicity. And they're denoted in red and green. And the other 2 cells then specifies, depends on what you want to specify, you can assess it so that efficacy is judged more important than toxicity, or vice versa. But we don't need to go into the details. Essentially what you do with the Boeing 12 is you escalate, de-escalate based on safety first. First in human safety is always important. And then whether you escalate or you stay or you de-escalate, you start looking at the number of patients who were treated at the dose, the number of patients who experienced toxicity, and then the number of patients who experienced efficacy. So within this framework, you're looking at both efficacy plus safety. We've simulated 16 different scenarios. Now I'm not going to go into them, there's a lot of numbers on this slide. What we did was we looked at cases where the toxicity might slowly increase over time, efficacy increases over time, where efficacy might plateau after a certain dose, where it might start decreasing. To illustrate the differences, I want to focus in on scenario 9, which is plotted here. And this is one where the dose toxicity slowly increases over the 5 selected doses, but efficacy actually decreases from the first dose. An example might be saturation of the receptor. The Boeing, which is in red, clearly just selects dose 5. And that I've already stated that that's better than a 3+3 design. Well, what happens is here, all you're doing is focusing on the toxicity, so it enables to go all the way up to the highest dose. Whereas the Boeing 12 is focusing on both efficacy and safety, so it's focusing on both. It means it's being constrained, it's taking just dose 1 in most cases. In all the simulations, a statistician and a clinician went through the data to identify what the optimal biological dose was, and those are given in the second column. The Boeing, which by design is aiming to identify the maximum tolerated dose, only selected the optimal biological dose 3 times, whereas something like the Boeing 12 identified it in nearly all cases, which is not a surprise because you're actually got a study design looking for the optimal biological dose. There are other designs out there, I'm not going to mention in any detail. There are things like the merit design. You can go to the MD Anderson site and you can read up about it, and they've got free software here. So you can use the merit design, but again, it's looking at benefit risk, not just looking at safety. So what might a future development program look like? Well, this is one that's been submitted to the FDA. We're still waiting for feedback. What we've done is we've used the Boeing design for the MTD. The sponsor didn't want to go fully out with looking at benefit risk. They still wanted to focus on safety, so they did something called the Boeing design, which was aimed to find the maximum tolerated dose. But then in terms of the expansion phase, rather than a single dose, they did 3 doses. So again, they've got 3, the maximum tolerated, that's for the Boeing, the middle one, which they're expecting to be the optimal dose, and a low one. And what they've done is 3 interim analyses, 2 for safety, and the middle one looking at benefit risk. And this one's gone to the FDA. If you're more ambitious, you might want to do an adaptive phase 2, phase 3, and save a bit of time. I'm not going to go into too much detail here, but it's a comparison at the end of standard of care drop-in doses. There are issues associated with that. So what are the challenges? Well, clearly we're going to have more patients. If we're studying more doses in the expansion phase, we're going to have more patients to do that. And we're potentially exposing more patients without first demonstrating the therapy clinical activity, which potentially will increase the number of patients to ineffective doses. And it could well be problematic with life-threatening diseases, as we're facing, where we're asking patients to potentially be exposed to subtherapeutic doses. So researchers like myself need to balance speed. We want to go to the authorities with the drugs to get to market as quickly as possible for patients, with the uncertainty, and we've got to balance the speed with the exposure of patients of being done to subtherapeutic doses. Programs are going to be bigger. Phase 2, phase 3 are going to be bigger, and they're going to take longer as well. That's one of the consequences of Project Optimus. So in summary, Project Optimus is here, and it's taken shape and is influencing the industry. Its aim is to reform the dose optimization and dose selection paradigm in oncology drug development. So no longer can we try and identify the MTD, the maximum tolerated dose, and use them. We have to do research to find the optimal biological dose, which means that we're going to see it take longer in early phase. Researchers need a range of different study designs. It's no longer one size fits all, like everybody going for the 3+3, which, although it doesn't adequately, in my opinion, identifies the maximum tolerated dose. But we researchers need a range of different study designs and analysis methods, and we need to deploy them depending on the study objectives and the property of the therapy and the investigation. It's important at the beginning we actually state what the objectives are, make it clear whether we're going after the MTD or the optimal biological dose. And we need to state assumptions and discuss those with the agencies when designing our early phase development programs, especially in identifying the dose. But it's here and it's changing the drug development paradigm. With that, thank you very much.
Thank you very much. So we'll move to the next speaker. It's an honor to introduce a long-term friend of mine, Dr. Al-Madinah. So he is also a professor at King's College, London, and he is also the head of biostatistics in clinical counseling. And he has been involved since 2000 in various clinical projects, with all leading research internationally in both academia and industry. He also sits on the UK MRC funding committee and also has about 37,000 citations in his name. He also being associate editor, including BMJ programs and DPI. Thank you for speaking. So he's going to talk to us about the role of real-world data in clinical trials.
Thank you. It's an honor to present the POSS 2025. In these presentations, we are going to answer the role of real-world data in clinical trials. Slightly different than previous talks, but it's about drug development. I will start with a couple of definitions because it's quite a large field of research, and I will present 2 examples, let's say, on this definition, 7 years. Each will be reduced in the case. So let's start with the definition of real-world data. There are data related to patients' health status, or it can be healthcare, routine collected from hospitals or from registers or colleagues or business sources or clinics. Recently, there is an important also in the trials by completing traditional non-medical trials, providing insights of treatments, effects in the real life setting, as well as facilities is control for real data from registries and from health results. The other things that I will introduce is the real world evidence, because we have data and it is for a purpose. The purpose is about providing clinical evidence for therapy. So real world data is the clinical evidence about the use of potential benefits of risk of a medical product or a drug from data or from routine results. Recently, it has been used in regulatory tests for safety, health technology assessments, as well as completing some information on specific therapies or clinical trials. Real data in clinical trials has several benefits of the life sciences sector. It's enhancing trial design and feasibility by informing the design of for example, early stage trials. They have some information sometimes coming from real world data. Supporting regulatory approvals and basically supplements data that are planned in trials, improving generalizability by accessing to different subgroups or groups that are hard to reach. Of course, the post-marketing and pharmacovigilance has been in place once again, which monitors safety in patients. And the last one, which is quite interesting, of course, the hot topic at the moment is about enabling decentralized trials. Basically, how to improve the trials by introducing digital health technologies. So, data are everywhere, and data are important. But have some challenges. One of the common challenges for those working with the data is about awareness control. And another one is more clinical, is about the evolution of the disease, which the accuracy and confidence. There are some data, for example, the calling of molecular interactions that doesn't tell the specific features of the disease. So we have this challenges with data. Another one, which is addressing potential biases in inheritance in observational data, provider bias. I have some recently about COVID data on provider bias. This is the company for 4 years. You see, it's a huge amount of papers around COVID. But if you look at them, some of them have valid, and I have a paper around this, particularly the resolution and ethnicity and outcomes, and basically about products and how to avoid those. There is some challenges about ethical issues, and this is mainly around the privacy. However, real-world data is also forming clinical trials by making them more patient-specific, efficient, and representative of the real-world data. So talking about the evidence, we have to look about what is the evidence level. And for those who are familiar with guidelines, they use this level of evidence, which is 1A, when they use to do sequence clinical trials and clinical trials. 2A to be about observational studies, those systematic review of observational studies and post studies. And this is area where real-world data has benefits around how to provide information or value information or observations. So, before I move on to the examples, I would like to introduce two definitions, which I'd like to remind you about. What is efficacy and effectiveness? So, if you look at efficacy is the extent to which the person does more good than harm under ideal circumstances, as it was most people do in clinical trials. Effectiveness is beyond the clinical trials. It is the extent to which an intervention does more good than harm when you provide it under the usual circumstances of healthcare practice. Basically, in hospitals, you develop a product which is approved, so how it's performed in hospitals. And there is difference for evidence between randomized controlled trials and real-world evidence. Of course, the first one is even when about is randomization. You see, evidence we don't. In randomized controlled trials, sometimes the drug is approved by excluding some patients that don't have any, for example, or non-adherence to treatment. In the real-world evidence, we have some challenges with everyone, including those who are on different drugs or switching from one drug to another. It's very challenging, and of course, you can tell that the real-world evidence has heterogeneous patients, so there are two challenges. But that is the real world. That is where we want to make impact, is on all patients. They are not replacing each other, but they are competing. The source of real-world data is area claims, hospital claims, or provider claims, or disease registries, or economic protocol, or social data, and all of them are acceptable in the regulatory. I will give some examples from FDA approval. So there is two drugs here that both of them has accepted data from real-world data. The first one is about eczema, which is for rheumatoid arthritis, where the dossier included the application included data from 3 claims studies, plus one randomized controlled trials. For those who are familiar with FDA, they need to randomized controlled trials. Here, the early one, which is a change. Another one, the same disease area, which is IBRA, which is 3 double-blind SOTs. Trials, one label, 4 meta-analysis, which sort of data for development, 1 program label, and 5 registries. So there are some guidelines published recently in regulatory websites, EPA, EMA, much better. International regulatory guidelines how you do this in dossier. So now I will talk about 2 studies that I was involving. The first one about to do with it can be linked to oncology. It's about measuring the impact of monoclonal antibodies or antibody therapies. This study was commissioned by the Al-Madinah Research, and at the beginning they asked us to look at all of them. And in all oncology, that's quite challenging. So we end up doing a scoping review. We end up 1 disease, 2 diseases, but oncology is 1 is skin cancer. And we looked at 5 months, 5 months. So these months, treatments have significantly improved the quality and quantity of life recently, but have some difference cost, emotional cost. So the aim was estimating the effect of these drugs and do some economic evaluation. We looked at 5 different maps: adalimumab, pembrolizumab, ipilimumab, nivolumab, and combination between EP. So we looked at survival and opportunity survival trial as well as POSS using ET5P, sorry, and POSS and some evaluation. We can make that analysis of 27 initial real data and 26 systematic review from mathematics. And of course, we have some simulation. Using this data, we have done some simulation for using this. We have done some human ethical simulation. So this is the result. I'm not going to go into details. So the first challenge is we look at the data or systems we don't have the comparator. Don't have all the comparators in one. So for example here, the dots in this in here, the line dots is where we don't have any data as measure the effect. So we use here what we call historical analysis. So by measuring the effect with different probe, we can derive what is the effect. Let's say here, if we have looked at the EP against level, if you don't have EP, but we can derive that using the analysis. And as you can see in the forest plot, it has so the reference is level one is commonly used, and from our plots clearly you can see the combination between level and EP is that it has a protective effect, which is favorable. We done a probability evaluation. I won't go into details, and so similar result of the EP this niveau is most expensive to take into account the length of life gain with the treatments. And again, we have the net monetary benefits they need here to profile case for positive for nivolumab and the combination between EP and nivolumab. The rest have negative monetary benefits. But I can't talk into details on this because it has nothing to do, but it has advantage in how to do this. The second one, which I do at the moment, is about thrombectomy. Thrombectomy is an intervention after stroke. So the asthma trials have shown that better survival and disability at 90 days. And what we want to see if this is true in practice, and as well as looking at long-term, because stroke is a long-term condition. So we have, for example, as one year. So we used here, so we used the efficacy and safety of this, and we can turn on national data, which is national audit that's included independent Wales and Ireland. So basically we have people seeing the first episode, and we looked at the thrombectomy, patient with the thrombectomy, and we matched them with those who didn't receive a thrombectomy, but we have the same characteristics, same age, same severity, and so on. So we then asked to evaluate the real-world effectiveness and safety of ET, and to compare what we observe in the real-world data, is it replicable? And also example in randomized control trials, is it replicable? So we use a method called propensity matching, and we match by age, gender, disability, severity, as well as some cases like country of operation varieties, when they arrive to the hospital, and whether they are hospitalized or not. The outcomes we use the MRS, modified time scale. 02 is less available, for 0 is not available. So 3 and 5 is a level of disability. And we use as well as the last one is as 90 days. So among patients analyzed, we analyzed for this period of time 600,000 more than a million patients for first day of stroke, and we identified 12,000 So looking at the results, and here we have Al-Madinah, there is mortality on the left, and we have recovery, which is measured by stable on the right. So the treatment group, which is in blue, is associated with almost 1 reduction, or 24% reductions in the risk of death, compared to those who get the total. I am talking about they are much like hybrids, basically like the twins, without much those who get looking at recovery, which is national recovery, activity, outcomes to scale, so that's discharge. And in patients who underwent unfortunately have a significant increase of anti-illness outcomes, and it's about 20% improvements as risk measured by operation shared here. Thank you very much.
Thank you, Professor. We've got about 10-15 minutes for questions. If you have any questions, the speakers.
This is an outstanding session, I think, all over for great talks. But I had 2 questions. One related to phase 1 design. And I heard several times you guys say, this is far superior, this one is markedly better. So the question I have is, how do you know they're better? One metric might be, if you look at phase 1 designs, look at different designs, one reasonable question a clinician might ask is, of all those designs, which one leads to the greatest number of FDA-approved or regulatory-approved drugs? Because the failure rate after phase 3 is huge, and one could reasonably argue, as FDA studies, that you don't have the dose. So how do you make the judgment it's superior or far better? And what metric are you looking at when you make that judgment?
So personally, I don't know. I don't look at the FDA acceptance rejection at that stage. By defining better, what you can do is simulate. And through simulation, you know what maximum tolerated dose is set at, or you know what optimal biological dose is set at. And what you then do is look at the performance of those designs relative to achieving that dose. Now, they're not 100%, as I showed you in some line, we do have variability in there, but generally, I would say that it's not the systems design, or the model designs are better, as long as you've got the model right. If you haven't got the model right, then things like model system designs come into their own lives. I think that's right. And when we talk about performance, we're talking not only about the ability of the design to identify the correct dose, the correct entity, or the other definitions, but also to minimize the toxicity burden on patients within the trials. So what we're looking for is an approach which is both accurate in determining the maximum tolerated dose and minimizes the number of patients who actually suffer DLT.
So to play devil's advocate, if I'm a patient, for superior design to one gives me the best efficacy, least toxicity. So if you're looking at it purely through the lens of toxicity, I agree that's a good lens. But maybe it's only part of the equation. What insights do you have that might suggest that the clinician trying to develop a drug for a patient sees that one design is better than another, both with regard to reducing toxicity
I mean, you saw from Philip's presentation that the Boeing 12 design is looking simultaneously at efficacy and toxicity. So if that becomes the most important, the risk benefit, then we should use those designs. And it probably is true that the maximum tolerated dose, whilst it was simple at the outset, I don't think it's the direction in which we should be going.
And also add that in today's environment, they're not even worried about efficacy. You look at the frequency screen, they're not looking at it from a patient's perspective and saying, well, it's doing really well. All you're doing is clearing the hurdle. Can I use that dose? Is it safe enough for one start doing that? Whereas if you start using some of these, I call it smarter designs, then you're going to start taking into account the patient perception and they may get some benefit. So it is good that medicine can be slow.
And there's a good answer to the confidence question. So I have been at FDA and ODAC countless times, and I have no records with but the question I have is, they now want you to explore multiple doses to compare the toxicity and establish the concentration effect relationships. So when we've done that, and the designs that have been proposed, it is a small number of patients that might be in a variety of cohorts, and it's never entirely clear what statistics or statistical basis you're using to say, oh, this dose is better, because there's no statistical power when you conduct these studies in accordance with their suggestions. And so how are you supposed to use Project Optimus with low numbers of patients to try to evaluate multiple doses, but recognize that there's no statistical metric around the selection of that dose?
So the simplest way I've done it is go for their fit for purpose initiative, for which they've said this design works. That if you want to do that, I don't think that's always necessarily the best. It gets you around some of the policies. So they've got a fit for purpose initiative, and they've actually got the Boeing design, the specific Boeing only. So one way to get around that is to use that design, to use their own rules against, I'm not necessarily saying that's always the best, because that's still estimating the maximum tolerated dose, and I think we need to push the envelope back out to start with benefit risk much better in the process.
And I would also say that the investigation of the dose response curve, and it's not just in oncology, has been woven over the last 30, 40 years. I did a survey from clinicaltrial.gov database of phase 2B dose ranging studies across the board, and the average number, the median number of doses studied was 2. And that's just not enough to characterize either the safety or the efficacy profile, the dose profile. I just think we need to, I would rather investigate more doses with fewer patients per dose and one, rather than try and get statistical significance between each individual dose and control.
I'll also add, it's all talking. When I first joined the industry, we did multiple dose ranging studies. We really did investigate the dose better in what we did. The commercial constraints of taking over to go back to your 2. But I was talking about some where they might have done 3 or 4 studies with multiple doses, but they didn't like that. But we just cut it. Science has got, it's negative. And I'm not that old, I say that.
I have one last question. I'm going to just put on my company CEO hat for you knew that was coming. So this is great. More doses, more precision, more numbers, got it. But it's time, it's money, and there's a finite exclusivity on the drug. And if I'm a drug company, and I work in bad, rare diseases, right, so it takes a long time to do a trial. Let's say it takes me 13 years, 15 years. It might take me 7 of those years to get to the phase 1, and I know plenty of examples where that's been the case in rare orphan cancers. How do you balance, sort of the reality of a pharma company that is going to put in tens of millions trials into a drug, and then the loss of the commercial funding to be able to get those dollars back. How do you balance all of these issues to get to the right place for the patient and the enterprise support?
I think increasingly we're looking towards adaptive. So if you start in the phase 2B dose response phase with multiple doses, then you can at interim analysis decide to drop ineffective doses or doses that have toxicity issue. You could consider an adaptive phase 2-3 study to compress the development time. There are all sorts of different approaches you could consider.
Our part rare diseases, because I think there's more options for rare diseases. But it's a simple choice. If you go ahead with a single dose, the FDA aren't going to give you a license anyway. So to some extent, you've got to go talking about what you want to do when you want to do it. The FDA have had enough to do post-marketing changes. And you might go there with a very simple common oncology and say, everybody else is going to turn it out and say, that's not good. And, you know, do it by all means, but you're wasting money trying it.
I will add about the balance and the things that we mentioned, especially in science, is about preclinical data. Because if I want to invest, it has to be a good information brochure there, so good animal data, and that will help where to start. Because starting at there is not an easy question. And after, are you going to double it, or are you going to triple it, or how will be steps? Adaptive design will help you with this, but animal study, for example, will help you where to start, and that will reduce the cost of the trial.
Yeah, I completely agree. I think animal studies are not using it better for scan. That's for sure. Thank you.
I think the math and the statistics you show are extremely elegant, but extremely complicated. And now that we have tools like DeepSeek and others, how do you foresee this closing the gap and making this done in a realistic time? Because the timelines are just too long. We all agree on that. From taking a drug to eventually getting into market, it's just too long. So how do you foresee this entering into this realm?
I still foresee problems getting patients into the trial. You say it's too long, it's the enrollment of the patients. You can turn around the analysis and do these things very quickly. It's identifying the patients who want to participate. It's still a great way to start for most of the class. The issue is the faster you recruit, the less ability there is to adapt within a trial. So there is, for any particular disease and the length of time we're following the patient, there's an optimal speed of recruitment. And you tell that to the operations groups in pharma companies, in which they've been given targets for the year of recruitment rates that don't allow us to utilize the more advanced adaptive trials.
In this Sunday, there's a panel talking about putting biodigital twins into the paradigm you're discussing in order to accelerate it. What are your thoughts about that?
Digital twins, you have to get the data from somewhere, real data, and not just simulated data. There's a feeling, and it's sort of been around for 30 years, that the future is in silico clinical trials. But the in silico needs data to be able to generate data for this in silico clinical trial. The ultimate would be to model the biological systems much more cleverly than we do up to now in order to generate and simulate data for in silico clinical trials. The complexity of that is enormous now. Maybe artificial intelligence
will help us, but I will hold your breath.
In the interest of time, so I think I'm sure the next session needs to start. Thank you very much for coming in. Thank you for your presentation.
Thank you, everyone. We will keep going for the second session because we will wait for John Ray. So I'd like to invite to Samir Al-Amoudi and Maya Jihani, who will be the moderator for this session. It is a leukemia session, so we will hear from Prof. Silvio to talk about CML, and then we will have Dr. Khalil Al-Fasi from Oman. He will give us a lecture about CML, chronic lymphocytic leukemia, followed by a recorded lecture from Prof. Pato Kambachian from India Lesson for acute plastic leukemia, and then Prof. Ihab Al-Hamidi from National Lab Jeddah is India School. So without any further ado, we'll go to satellite symposium sponsored by Novartis for Prof. Silvio. Prof. Silvio is a well-known hematologist in our community. He is a professor of veterinary medicine and hematology at the University of Turin, Italy. He has a lot of publication and research in hematological malignancy. Prof. Silvio, thanks for being here with us. The floor is yours.
Thank you very much. Thank you for the kind invitation. I'm very happy to be here. It's not my first time in Al-Madinah, but it's always passionate town. So I will do some disclaimers, and I will say that nowadays we obtain results in chemotherapy thanks to the use of different types of TKIs. So it is 5, 6, 7, depending on which country you are giving different types of TKIs. The first line generally relies on two types of the traditional imatinib, and the second generation TKI, which are azacitidine and riluzole is approved as first line therapy, but is not very reimbursed in most of the countries, so it's rarely used. I would say that these trials, these TKIs, were needed then approval after a number of clinical studies, which are listed here. And showing, for example, the first one, the well-known is imatinib, the Gaius trial, which is providing a very good overall survival after 10 years from the start of the therapy. You see that there is a small difference, but in most of these patients in the red curve, we moved to imatinib shortly after the start of the therapy because of the superiority in preventing progression of the disease with respect to the treatment. So this is generally what we can obtain from using the imatinib therapy, which has been, of course, confirmed by many other studies. Another studies important is the NSNP study, which provided the idea that second generation TKIs, in which imatinib is used at different dosages, for other mechanisms with respect to imatinib, was provided the fastest achievement of MMR with respect to imatinib. Similarly, shortly after, azacitidine was also approved as first-line therapy because of similar results, highly rated. Unfortunately, these, the follow-up of the study ends after 5 years. But you see that there is a superiority in achieving the MMR, as well as an increase in our patients achieving very big molecular response, like MR4, MR45. But so again, comparing what we have obtained using the imatinib or single generation TKIs, these were the data that some can be summarized, and you will see that, however, some of these data are probably more important than others. Certainly, we know that second generation TKI do not improve overall survival, but overall survival in patients with Al-Madinah is so good that it's very difficult to overcome the threshold of established and therefore this is not a reason. The second most important aspect is where they use second generation TKIs is in favor, of course, of second generation TKI, faster and deeper molecular responses, in particular in Al-4 and Al-4.5. And finally, are associated with, unfortunately, with more long-term toxicity. This is something against the use of second generation TKIs, particularly in patients which are affected by other comorbidities. All the other aspects which are reducing the risk of early progression of similar death is questionable, because we've seen also many progressions and similar death that use of second generation TKIs. And the recovery are more expensive is also declining, because at the moment the patent expired for both the neurotic and the substance. Therefore, we have generic protection. They are a little bit more expensive, but not, I would say, as expensive as before. So, how many patients achieve, however, a deep molecular response? To achieve a deep molecular response is very, very important. Of course, if we want to try something, which is also possible. If you're using second generation TKI, we achieve 30% of the patients who are ready, which means that they are in MR4 and 4.5 for at least 2-3 years from the start of the therapy to try to discontinue the therapy. And to obtain the same result, we need at least 10 years to do it. So altogether, I would say that we have to pay a price for in terms of toxicity, because second generation TKIs are more toxic. This is an example, for example, of you see of the log neighborhood in which the cardiovascular events are increasing with time, particularly in patients treated with chronic twice a day. But the patients who are achieving at the moment the deep molecular response are really obtaining a successful TFR are only a small percentage, around 15, maximum 35% of all the patients, of the total population of similar patients. So, how this scenario will change with the shingling therapy? I would say shingling is a different type of TKI. Shingling is in approved now as first one by the FDA, not yet really known, but probably soon will be. And you can see that indeed is different with respect to the other TKIs, because it's not linking the antibody pocket, where almost all the other TKIs are binding, but is linking the releasing side, which is essential just for maintaining the conformation of this virus in a closed, inactive conformation. And this is highly specific, more specific for Addison and BCR-Addison, and therefore we expect less of target effects with respect to the other TKIs, because the antibody is shared, Addisonalities are shared with other TKIs, and of course this will be responsible for side effects that have nothing to do and we do not have to do with our disease, I'll say now. Second point is not, should be expected not to be affected by the mutation, at least the same mutations, which are affecting the antibody pocket and the cause resistance. So we know that it was first introduced, it is also available again in Saudi Arabia. The Assemble test, there was also a study, the Assemble study, which was comparing Ashiminib, the dosage of 400 milligrams twice a day, is the same 80 milligrams once a day, with respect to 500 milligrams once a day. And there was a clear superiority achieved with respect to Zubin, which was a good choice, still like that, in particular for patients, of course, lacking activity amputation. In the study, indeed, one criteria of exclusion was just the presence of the amputation. And you may see that already after 6 months, there is already a very good advantage in terms of MMR with respect to Zubin, and this is also increasing a little bit after 1 year. And also the secondary endpoint, which was the secondary endpoint was also definitely incredible. But what is striking is the tolerability of this drug in patients who were really needed for at least 2-3 different TKIs. And you will see that more than 50% of the patients are still treated with the inhibitor with respect to only 25% of those who treated with Bosutinib. And this means one important message that the drug is effective and very well tolerated. You will see that this is an important aspect that will be considered in the treatment of patients that they treated previously for a quite long time. And then, due to this high level of tolerability and this high effectiveness, indeed was tested as first therapy against the other TKIs already approved as first therapy, Madinah and second generation TKIs. So was again achieved against the rest of the world, we can say, and you see that the randomization was 1-to-1, one achieved and one or Madinah or second generation according to the selection of the doctors. And the primary endpoint, which was the MMR level after 1 year approximately, you will see that it's still able to achieve because all the other content of achieving Madinah or second generation TKIs. But what is even more relevant, I think, in my opinion, after 1 year, there was a very high percentage of cases achieving M4 and also a good percentage of those achieving 1.5 with respect to the population. But of course, the confrontation, because the advice particularly something suitable for patients who are young, and so they have benefit the outcome from this combination therapy, is versus the second generation TKIs. So the last column, as you can see, the M4 already is clearly an advantage for achievement with respect to second generation TKI as well as 4.5. So this is, however, these are data 96 months, weeks, sorry, so almost 2 years. So we expect this difference will increase throughout the time. And another point, which is similar to what we have seen in third-line therapy, is that the number of patients who are continuing with therapy is very high, 81%, which is much higher than expected to what we have with the Madinah, but also the second generation TKIs. This means that more patients can benefit and they can tolerate very well the first therapy regimen. Another point which is important in the confirmation of the second generation TKIs, the analysis, and there is an advantage, in particular in the intermediate high-risk group LDS, which are the worst, particularly high, is the worst type of, I would say, group of less risk group. They are affecting approximately altogether 1/3 of approximately patients, 2 of them, and for the intermediate 1% of all the patients for the high-risk score. And you see that there is an advantage with respect to the low. So the low, as we will see later, is, I would say, which are representing approximately 60% of all patients. These are patients who have very, very good prognosis and the treatment of that to is that the patients over the age of 75, as you can see, they have a very young age, which means that this gap is very well. Of course, after 75, or we are looking a little bit less in respect to the gap, so there's but however, this means that the gap is very low. Another point which is correlates very well from the percentage of achievement of the deep molecular responses is the time in which we have we have achieved levels of 1 or less than 1%. As you can see, it's almost half, and also the measured molecular response is definitely achieved in a shorter time with respect to what we have with cell conjugation has. This, in spite of the fact that it is much very well related, and I would say that the residence leading to this population, as you may see, is very low with respect to all the market conjugation PPIs, and also the adverse events leading to those adjustments according to the Russian. You may see, particularly with second generation PPIs, you are frequently to interrupt or adjust the therapy because of side effects. And these are the side effects of grade 3 or more. And you may see that hematological toxicity is not so different, but this is a different aspect, because hematological toxicity is something which is due to a defect in disease, so it's similar rather than action, direct action of the defect that we are using. But all the other events, particularly the increase of liver enzymes, as well as base and so on, or pancreatic enzymes, is definitely low. So these are the conclusion of the Shimon. I just have to be on time, I will escape this conclusion, which should be quite clear for you. I would say that indeed I would like to recall in just 2 slides that the data presented by another independent study performed in Australia by a group of teams which were using a Shimon therapy in a small group of patients, only 100 patients, and these were the scheme of the study. As you may see, Shimon 40 mg once a day, or 80 mg once a day for those who are continuing the same therapy. If they are not reaching whether the milestones established by the European Union, they can add other TKIs, the traditional TKIs, according to the discretion. But what is very impressive is that this study, after 2 years only, after 2 years even more, there is a percentage of about 55%, which is true in respect approximately in subsequent 2 years, 40% was successful to be part of the entire population study. And this is a huge number, so this represents the records approximately before. So although it will be quite expensive, probably specific subgroup of patients, the particular patients who need what are needed to achieve treatment remission, successful treatment remission, like women who want to become pregnant and so on. This is a very good value that should be, of course, considered. Thank you very much for your attention. I would like to thank also the international seminar. There will be something that probably we will ask you something next year. We have a cooperation with international foundation and partner. Thank you very much.
Okay, thank you. So now it's ready.